Good morning. Good morning, everybody. Good morning on this beautiful fall morning. Welcome to the 2024 Annual Breast Cancer Summit. I'm investigative reporter Kristin Thorne, and this is my 9th year hosting this event. Thank you. It's been a pleasure to be here every year. I really do look forward to it. I have learned more about this topic than I ever thought I would, and that's from being here and listening to all the panels that we have and the speakers. I'm thrilled to be here this morning and truly look forward to this event every year. This program supports breast cancer awareness, education, advanced medical practices, procedures, and technologies, bringing together industry, hospital, clinical leaders, and the breast cancer community. This yearly event provides a space for experts in the field to discuss how they are navigating the ever-evolving world of healthcare as it pertains to the fight against breast cancer. Breast reconstruction is an option for every woman undergoing breast cancer removal surgery. In fact, it is a story that we covered. Breast Reconstruction Awareness Day, or BRA Day, is an initiative designed to promote education, awareness, and access regarding post-mastectomy breast reconstruction. This initiative is a collaborative effort between the American Society of Plastic Surgeons, the Plastic Surgery Foundation, and plastic surgeons specializing in breast surgery. BRA Day occurs annually on the third Wednesday of October. This year, it falls on October 16th, today. So we are so happy you can be here today with us on BRA Day to promote education and awareness of breast reconstruction options. We will have a dedicated panel to this topic with the physicians of New York Plastic Surgical Group. Our program today will also explore updates in breast cancer screening, biomarker testing in the treatment of breast cancer, skin care and cancer treatment, genetic counseling, and exercise and breast cancer, which we know is so important. We are thrilled to have survivors in the program today to share their personal stories, one of whom is my friend and colleague, Stacey Sager, who also happens to be our keynote speaker today. Fun fact, in 2019, I was very pregnant with my daughter and was unable to host the summit that year when New York Plastic Surgical Group reached out. Stacey was my immediate recommendation because of her advocacy efforts and passion about educating on the topic of cancer. Today's exciting line of experts and real people sharing their stories is sure to both educate and inspire you. Throughout today's program, we encourage you to ask questions, network, and take advantage of community and health resources that may be of use to you. There is a wealth of information available literally at our fingertips. Our technology, even in the last year since I stood at this podium, has gotten so much more advanced through artificial intelligence. Everyone, I'm sure you've noticed this. You've been on Google, Instagram. The search produces AI responses. It's incredible how you can get such pointed, precise, specific information. Kind of scary sometimes as well. And it is evolving and getting smarter every day. However, it isn't a substitute for true experts. AI doesn't know what it's like to have human experiences. Thank goodness, not yet. And being diagnosed with a disease such as breast cancer, or what it's like to watch your mother, sister, or friend deal with a breast cancer diagnosis. Being here today, patients, survivors, and family members can obtain both authoritative information and interaction with the experts. We will be doing Q&A after our clinical discussions. However, if we are unable to get to your questions or you have just general feedback you'd like to share with the team here, please be on the lookout in your email for a post-event survey. Those are really important for the team here. They'd love to hear from you. Anything that you have to say about the event is going out this afternoon. They would love your feedback and to give you the opportunity to present any unanswered questions you may have. We will do our best to address them post-event, where we will publish Q&As that we were unable to get to today. The presentations you're about to see will be filmed. An edited version of today's program will be made available to you on the event website, breastcancersummit.com. Help us spread the word when posting to social media. Please be sure to use the hashtag BreastCancerSummit and please tag @NY Plastic Surgical. Lastly, we have some amazing vendors. I know everyone's been visiting them today, including our sponsors who are instrumental in making this public service event possible. Please join me in thanking Allergan and Compression Medical, our two presenting sponsors. We invite you to spend some time visiting the area out there with the exhibits to learn more about medical and community resources available to you. At this time, I'd like to invite Dr. Tomasa Adana to the podium. Dr. Adana is a board-certified plastic surgeon and president of New York Plastic Surgical Group, the founding organization of this event.
Just give me a second while I'm going to slide this over, otherwise I'll be standing here, and that's a bit much. Does anyone know, well, for starters, Kristin, thank you so very much. Kristin gives her time to come here and to join us. She's obviously, as we know, a multi-Emmy award-winning investigative reporter. This is her donating her time. So thank you again for all of that you do for us in education. So every day has a national holiday. Does everyone know what today's national holiday is? Donuts. Besides Bra Day, and not Donut Day or Cheeseburger Day. I had to pull it up so I got the nomenclature absolutely correct. It's Boss's Day. So how does this Boss's Day, right? True story. So this morning I'm at the gym. This is not about me, Dr. Zippalaeus. I know what you're thinking here. So I'm at the gym this morning, and my colleague, my buddy goes, you know, today's Boss's Day. And I look at him, and I go, uh-huh. He goes, well, you're a boss. I go, I'm a married man with 3 children. I do not delude myself into believing that I'm a boss. I'm well aware of how the world works. For those of us that are curious, Boss's Day is celebrated for employees to thank those bosses that allow them to do their job. So to all the mothers, to all the wives, to all the sisters, and to all the daughters in the house, thank you very much for allowing us to do our jobs. While I do have an administrative role here at New York Plastic Surgical Group, I still have the opportunity to treat patients. It's really what keeps me going. It's part of what I enjoy the most during my workday. The opportunity to educate patients and provide information for patients to empower them in their decisions with regards to breast cancer treatment and reconstruction is not a one-size-fits-all setting. The reality is our goal on the physician side is to try to tailor care to specific patients. On behalf of my partners here at the New York Plastic Surgical Group, we are proud to host and produce this annual event. We're excited about our fantastic lineup today of presentations. I hope you leave with information and resources that inspire you to guide and best guide and treat the treatment that we need as a survivor and supporter or caregiver. Developments and updates in the field of breast cancer are happening all around us. AI has been playing a significant role. Kristin already mentioned it. I suspect by next year we will have higher levels of AI involvement. From this most recent year, past April, the U.S. Preventative Services Task Force updated their guidelines recommending that women with an average risk for breast cancer receive a mammogram every 2 years starting at 40 instead of 50. To that end, please allow me to introduce Dr. Irina Rappaport. Dr. Rappaport is an associate professor of radiology at NYU Long Island School of Medicine. She is board certified in radiology and specializes in breast imaging at NYU Langone Hospital, Long Island. Dr. Rappaport will be speaking to us about updates in breast cancer screening. Dr. Rappaport? Thank you. Welcome, Irene.
Thank you. Good morning. Thank you so much for inviting to speak here today. I'm very honored to speak on this important topic about updates in breast cancer screening. I have no disclosures. So today we're going to speak a little bit about breast cancer statistics, about screening guidelines for average risk and high risk patients, and modalities that we use in breast imaging, including mammography and tomosynthesis, breast ultrasound, breast MRI, including abbreviated breast MRI, and also contrast-enhanced mammography, molecular breast imaging, and a little bit about AI. So breast cancer is the most common cancer among American women except for skin cancer. About 1 in 8 women in the United States will develop invasive breast cancer during their lifetime. Breast cancer is the second leading cause of cancer death in women after lung cancer, and all women are at risk. The American Cancer Society estimates for breast cancer in the United States for 2024 are almost 311,000 new cases of invasive breast cancer will be diagnosed in women. 42,250 women will die from breast cancer. But there is hope. When caught at its earliest localized stages, the 5-year relative survival rate is 99%, and there is more than 4 million survivors. So it's extremely important to raise awareness of breast cancer and screening. As you can see from this chart, mortality from breast cancer decreased by approximately 30% after mammography was introduced in 1990s. And mammography currently is the best available screening method that we have. It's a gold standard to detect breast cancer at its earliest, most curable stage. 5-year relative survival rates for breast cancer are 99% when it's localized, 86% when there is regional spread, and it decreases to 31% when it's at the distant stage at diagnosis. So mammograms are extremely important because they can detect cancer early when it's most treatable. And mammograms can show changes in the breast up to 2 years before patient or physician can feel them on exam. And average size of cancer diagnosed at screening is 12 millimeters. So there are various screening guidelines, and here is the list of all different organizations from least conservative to most conservative. According to American Cancer Society, women between age 40 and 44 have option to start screening with mammogram every year. Women 45 to 54 should get mammogram every year. And women 55 and older can switch to mammogram every other year, or they can continue mammograms yearly. USPSTF guidelines were updated this year in April, and now recommendation is that women between ages 40 to 74 should get mammogram every other year. According to American College of Radiology and Society of Breast Imaging, mammography should start at age 40 and continue every year, and should continue until the patient is in good health. And according to all organizations, this method will save the most lives if we can start at 40 and do it every year. So why do we start at 40? Breast cancer incidence increases substantially around age 40. Incidence rate for ages 40 to 44 is twice that for ages 35 to 39. And it continues to increase with age. So that's why we start at 40. There is always a lot of controversy to start at 40 or 50, to do it every year or every other year. And from this table, which is a summary of multiple studies, we know that reduction in risk of dying of breast cancer is the most, 40%, if we do it yearly from 40 to 84. It's extremely important to keep our most vulnerable population in mind. So breast cancer death rate in the United States decreased by 43% in white women since 1980s, but it decreased only by 23% for African American women. African American women are 42% more likely to die from breast cancer than white women. The risks of being diagnosed with more aggressive triple-negative breast cancer is twice as high for African American women. And African American women are less likely to be diagnosed with stage 1 cancer, but are twice likely to die of these early breast cancers. And African American women have higher risk of BRCA1 or BRCA2 genetic mutations than women of Western European ancestry. And that's the reason it's extremely important to do risk assessment at age 25. The guideline used to be at 30, but now it decreased at 25. All women should undergo risk assessment by age 25, and especially African American women and women of Ashkenazi Jewish heritage. so we can identify those at higher than average risk and start appropriate screening. So higher than average risk subgroups include patients who have more than 20% risk of developing breast cancer during their lifetime. And these patients group include patients with genetic mutations. The most common is BRCA1 and BRCA2. Patients with family history, patients with chest radiation at young age, patients with personal history of breast cancer or high-risk lesions, such as atypical ductal hyperplasia and lobular carcinoma in situ, and patients with increased breast density. This table that we can see on ACR website lists other genetic mutations that we need to identify and start appropriate screening. So for high-risk screening, breast MRI is the supplemental screening method of choice after mammography. MRI screening should start at ages 25 to 30, and annual mammography should start between ages 25 to 40, depending on the type of risk. Mutation carriers can delay mammographic screening until age 40 if annual screening MRI is performed as recommended, so starting at ages 25 to 30. Women diagnosed with breast cancer before age 50 or with personal history of breast cancer and dense breast tissue should also undergo annual supplemental breast MRI. Other women with personal histories, such as history of ATP on biopsy, should consider screening breast MRI, especially if they have other risk factors. And also, women who have dense breast tissue as their only risk factor can also undergo screening supplementary with MRI. This is another large table that we can find on ACR website, which summarizes what we just discussed. So this is a normal mammogram. We can see darker areas represent fatty tissue and lighter areas represent glandular tissue. On mammogram, we are looking for masses, as you can see on the left, calcifications, little white dots in the middle picture, and areas of architectural distortion. These are presenting signs of breast cancer. So I will show you a few examples of cancers that are detected by annual screening mammograms. So this patient presented for annual screening mammogram. There is a small mass in the left breast. This is a magnified picture showing small irregular mass. At ultrasound, it measures 8 millimeters. So that was invasive ductal carcinoma, very small at diagnosis and treatable with good prognosis. Another example, 43-year-old woman presenting for annual screening mammogram, which detected calcifications. We can see in the right breast, which was DCIS, ductal carcinoma in situ, which is stage 0, very treatable cancer. And another example, baseline mammogram, 40-year-old patient presenting for mammogram. There is a mass in the right breast. It's 1.4 centimeters, and surrounding calcifications, 8 centimeters. So it was also early stage 1 breast cancer with negative lymph nodes and treatable. And I will show you some examples of more advanced cancers. We don't see these examples when patients come every year for mammogram. So this patient came in for the first mammogram with pain in the left breast. We can see 2 large masses and skin thickening. Breast looks denser. On ultrasound, we can see very large 2 masses, skin thickening, and abnormal lymph nodes, meaning there is metastatic disease in the lymph nodes. So it's more difficult to treat. And this is another mammogram. Patient came in first time because her friends told her that mammograms are painful, which is true, but only for a few seconds. But here we can see that in the right breast there is a large mass almost replacing the breast, a lot of skin thickening, and the patient had metastatic disease at diagnosis, which is harder to treat. So mammography is an excellent tool that we have. It has some limitations. So overall accuracy of mammography is 87%, but it could be smaller in patients with dense breast tissue. So what is breast density? We always talk about breast density. So it's a relative proportion of fat to glandular tissue. So darker areas on the mammogram is fat and lighter areas is glandular tissue. And cancers also look light on the mammogram. So they're harder to detect when there is a lot of glandular tissue. So this is example of fatty mammogram. This is example of scattered fibroglandular densities to 25 to 50% glandular tissue. This is heterogeneously dense breast tissue, and this is extremely dense breast tissue, more than 75% glandular versus fat. So risks of having dense breast tissue. It's harder for us to see breast cancer in a dense tissue, and also there is increased risk of developing breast cancer. So there is 5.3 relative risk in patients with extremely dense breast tissue relative to patients with fatty tissue. So here we can see example of very small carcinoma in the right breast, easily seen in fatty tissue. In scattered tissue, we can still see this irregular mass on the left. It's harder to see in heterogeneously dense tissue, but still possible. But in extremely dense tissue, it's even harder to see unless other signs like calcifications or distortion develops. So density awareness history started in 2004 when patient Nancy Capello in Connecticut was diagnosed with stage 3 breast cancer after a normal mammogram. And that happened because as she learned, she had dense breast tissue, and that's when she started movement to bring awareness of tissue density. She started moving Are You Dense? And slowly it became a law. It's actually effective this year, September. MQSA mandates that all women will be notified of their breast tissue density in a letter. So either patients receive a letter that the tissue is not dense or dense. And if it's dense, it's not abnormal, but we should discuss risk and any supplemental screening with physician. So again, mammography is not perfect, and one of the limitations is that there is tissue overlap or superimposition on 2D mammogram. So tomosynthesis was one of the advancements that was developed to improve mammography. And it's a better mammogram that minimizes effect of structure overlap within the breast, so we can see everything a little more clearer. Tomosynthesis leads to better detection and also decrease in callbacks or unnecessary workups. It was approved in 2011, and tomosynthesis creates three-dimensional picture of the breast by acquiring images at multiple angles, and then they're reconstructed into thin slices, and we can scroll through the tissue to see abnormalities better. So this is explanation of tomosynthesis. So on 2D mammogram, this small cancer could be obscured by surrounding breast tissue, but on tomosynthesis, we can scroll through the slices and we can see abnormalities better without superimposition. It's similar to chest X-ray versus chest CT. Some cancers could be seen only on tomosynthesis, as in this example. 2D mammogram looks normal, but tomosynthesis detected very small area of architectural distortion, which was invasive ductal carcinoma. And another example, we can see distortion in the left breast only on 2D image. Tomosynthesis has great performance in all tissue types, but it's best for scattered fibroglandular tissue and heterogeneously dense breast tissue. Radiation dose is a little bit increased with tomosynthesis, but it's still small and it's well within recommended limits, and benefit of this increase definitely outweighs the risk. So overall, tomosynthesis helps to detect cancers earlier, and another major role, it decreases recalls or unnecessary workup. So besides mammography, we use more screening, supplementary screening, and the most common test that we use is ultrasound. Ultrasound detects additional 1.8 to 4.6 cancers per 1,000 of exams. Screening mammography detects 2 to 10 per 1,000. Majority of cancers identified with ultrasound are invasive cancer rather than ductal carcinoma in situ, and the majority are very small, node negative, therefore lead to better patient outcomes. Screening ultrasound works only in patients with dense tissue well because cancers are dark on ultrasound and glandular tissue is lighter. So this is example of small invasive carcinoma in the background of dense tissue. So this is mammogram that I showed you earlier with extremely dense tissue where we cannot see cancer. But ultrasound demonstrates two very small, under a centimeter, irregular masses that turned out to be invasive lobular carcinoma. Again, very early, node negative, and with good prognosis. And another example, dense mammogram, which looks normal, and ultrasound demonstrated 6 millimeter small invasive ductal carcinoma. Screening ultrasound is not indicated for patients with fatty or scattered tissue because it looks dark and surrounding fat looks dark, so they don't stand out. We can still see it, but it's much harder to see in fatty tissue. So ultrasound is usually only used to perform biopsy in these patients. Ultrasound drawback is that it has a lot of false positive. But I will explain why. So this slide demonstrates three masses. They all look very similar. And one of them is invasive ductal carcinoma. There is also cyst with debris and fibroadenoma. So about 10% of invasive carcinoma can present with benign appearance, round or oval masses, and only biopsy helps us to differentiate, to find those 10% of carcinomas with this appearance. So screening breast ultrasound does increase detection, but it has false positive and short-term follow-ups, which is a drawback. And initial studies showed that it has very low positive predictive value for biopsy. But more recent studies have favorable results. Cancer detection rate increases up to 7 per 1,000 in more recent studies. And positive predictive value for biopsy is 42%, which is similar to mammography and MRI. So overall, there are pros and cons for breast ultrasound. At present, it's not indicated for majority of patients with significantly elevated risk, where MRI is indicated, but more studies are needed to see if it would be the test of choice for patients with dense breast tissue as their only risk factor. So mammography and ultrasound both have limitations in that we cannot include all tissue, and sometimes cancers don't produce anatomical changes yet. And both mammogram and ultrasound are only anatomical tests. And that's where MRI comes in. It's anatomical and functional test, so it could lead to early detection. Multiple studies demonstrate that breast MRI has higher sensitivity than mammography, ultrasound, and combination of both exams. Sensitivities and specificities are 96, 97 for breast MRI, and cancer detection rate is excellent. Majority of studies show 15 to 18 patients per 1,000 exam cancer detection, which is significantly higher than mammography or ultrasound. And cancers detected at MRI are smaller, more likely to be node negative, and there are fewer interval cancers. IV contrast is necessary for diagnosis. When we do MRI, all cancers enhance or light up on MRI due to neovascularity, and contrast makes the lesion stand out from surrounding tissue. So breast MRI is indicated for women with genetic mutations, women with lifetime risk of more than 20%, women with history of chest wall or upper abdominal radiation, women with personal history diagnosed before age 50, women with personal history diagnosed at any age and dense breast tissue, and for women with LCIS, lobular carcinoma in situ, MRI should be considered. So MRI initially was studied in high-risk patients, but more recently there are studies that demonstrate benefit of MRI in patients who have dense breast tissue as only risk factor. And studies, again, demonstrated excellent results with high cancer detection rate and less interval cancers. And presently, European Society of Breast Imaging recommends that patients with extremely dense breast should get screening MRI every 2 to 4 years in addition to mammography. So this is example of cancer detected on MRI only in patient with strong family history. Her mammogram and ultrasound are negative, but MRI clearly shows a small mass, 5 millimeter, in the right breast that turned out to be invasive ductal carcinoma. Again, very early lymph node negative, stage 1. Another example of patient, 48-year-old, she's BRCA positive. Mammogram and sonogram was normal, and MRI demonstrates very small area of, we call it non-mass enhancement in the left breast, which is ductal carcinoma in situ. Again, early stage of diagnosis. MRI also has some limitations. It's time-consuming and therefore costly. It requires contrast. It's difficult for some patients to tolerate, and patients with claustrophobia or abnormal renal function or with presence of metal cannot undergo MRI. One of the limitations of MRI was addressed, and ultra-fast or abbreviated breast MRI is developed. It consists of only one unenhanced and one post-contrast sequence. Conventional MRI usually has multiple sequences after administration of contrast. And therefore, there is decreased time and cost, but accuracy and sensitivity and cancer detection rate is excellent, similar to conventional MRI. So hopefully this would be in the future one of the more often used screening modalities. There are some other modalities that we can use for supplementary screening, and the most common are contrast-enhanced mammography and molecular breast imaging. Contrast-enhanced mammography is mammogram that is performed before and after administration of iodine-based contrast. It's similar to CAT scan contrast. And then the images are subtracted, so you can see abnormalities clearly. Like MRI, it's both anatomical and functional test, and it has great sensitivity and good cancer detection rate. Studies show up to 15.5 per thousand. And we can see clearly on in this example, carcinoma in the right breast, which cannot be seen on regular 2D mammogram. It has a lot of advantages and disadvantages, but I think the important one is that it still has smaller field of view, like conventional mammogram, compared to MRI. MRI would still detect more cancers because it includes more tissue. And presently, additional studies are needed to determine more definitive role of contrast-enhanced mammography for supplemental screening. Molecular breast imaging is another modality that could be used as supplementary screening. Technetium systemibi is used, and gamma camera designed for imaging of the breast. It's also functional and anatomic. It has good cancer detection rate, but smaller than MRI. It has not been widely adopted, mostly because of concern of radiation exposure, because it is higher for molecular breast imaging than for mammography. So currently, it's not recommended for supplemental screening. There are emerging technologies in breast imaging, including ultrasound transmission tomography, optoacoustic imaging, diffusion-weighted MRI, where we don't need to administer contrast, liquid biopsy, which aims to detect circulating tumor debris or markers in the bloodstream, and also artificial intelligence and machine learning. These are all in developmental stages, and more studies are needed to determine the role. So artificial intelligence starting to play more and more role in breast imaging. So far, studies show that it has similar or improved sensitivity and accuracy for cancer detection compared to readers, and it has a lot of potential to decrease recall rate, to increase conspicuity of lesions, to decrease radiation dose, and also it can play a role in breast cancer risk assessment. So this is an example of AI correctly identifying very small invasive carcinoma in the left breast. So I know there was a lot of information, and in summary, the points to remember is that all women should have risk assessment by age 25, and especially African American and Ashkenazi Jewish women, so screening can be initiated earlier. Average risk women should start screening mammography at age 40 and continue every year for as long as they are in good health. And this method will save most lives. And high-risk women should have annual mammogram and MRI. If MRI cannot be performed, we can screen with ultrasound or contrast-enhanced mammography. And all this information, majority you can see on ACR, American Society of Radiology, and Society of Breast Imaging website. And thank you again for letting me speak to you. Thank you.
My mic isn't on. Can you just, if anybody has any questions?
Do you have any questions?
Can you guys turn the mic on? I'm Noelle Natoli, one of the plastic surgeons, and
I don't think microphone is working. Maybe.
sorry about that.
Thank you.
Hi, Dr. Rappaport. I'm Dr. Natoli, one of the plastic surgeons. You've read my mammograms before.
Yes.
And is always kind enough to call me. So I have a couple of questions about the dense breast issues you talked about. One is, and this is mostly just asking you to repeat this for women in the audience, in terms of being declared dense breast, what is that cutoff? Like, is it 25% that you're considered you're dense, or?
Yes, so 50% and more would be considered dense, and 50 to 75% is called heterogeneously dense, and more than 75% we call extremely dense. So supplementary screening would be useful in patients 50 or more % tissue density.
And then my backup questions, and I have two of them, I'm sorry. In patients that are considered dense, is tomosynthesis what you recommend for them? And do they require a second modality, like ultrasound plus the tomosynthesis, or is the tomosynthesis adequate?
Tomosynthesis definitely helps us to see abnormalities better, so we do tomosynthesis. We actually do tomosynthesis for all patients because it does increase sensitivity in all tissue types, but mostly in scattered and heterogeneously dense breast. But I think ultrasound is very helpful. When there is more than 50% density, it's definitely helping to find more cancers. I know overall the guideline is that we should perform mammography and MRI possibly, but it's still not used everywhere, MRI. So the next best test would be ultrasound. It's more available.
And the last question,
Yes.
in terms of what you said, that European society adaptation, is that what our, in the United States, what our insurance companies like to do, be reimbursed?
That's a good question. Hopefully in the future it will be. Actually, recently we have great news that our governor, Katie Hochul, signed the law that's going to be in effect from January 2026, that patients who need supplementary screening, and that would include patients with dense tissue, insurances will have to approve it and pay for supplemental screening. It could be MRI or ultrasound, as I understand. Thank you.
I have another question right over here. Sorry, one more question. Oh, and then one more after that. Hold on. I have three. We have time for two more questions. Okay. I'm sorry. You can ask and then.
Yes, good morning. My name is Rosa, and right here.
Hi. My question, I was wondering if you recommend the Gallery early detection blood test. Do you ever use that to check for cancer in the beginning or cancer recurrence?
We don't use it yet for detection. It could be used to follow progression of disease, but it's in investigative stages. So hopefully it will be in the future, but not yet, presently.
And my other question was for 25, when they turn 25, checking if there's family history. Does that also go for males, 25-year-old males that have breast cancer in the family?
I believe general recommendation is for women to start assessment, but I'm sure it's as important to ask male patients the same questions. If there is extensive family history, we should pay more attention to breast exam if there is family history, or if there is actionable mutation that could be identified, we can screen for other cancers.
If there's no mutation, then it would just be an exam at the doctor, not necessarily
Right.
mammography or ultrasound. Okay.
Right.
All right, thank you.
Thank you.
I'm sorry, back to this side of the room. We had a microphone issue before.
Hi, my name is Rosa, and this year I made 2.5 cancer-free, breast cancer-free. And I'm a patient of Dr. Natali right there. And it's more of awareness, I guess, with dense breasts. I've always had dense breasts. And when I used to see my doctors before, they would never do the 3D because they felt that the MRI was enough or the insurance didn't pay. So when they found the breast cancer, was with the doctor, Natali said, I'm not touching you, I'm not seeing until you get a 3D. She called my insurance, they called me that same day, they approved it. So I don't know, maybe you spoke and I didn't hear about the insurance covering. And if it's that, do they cover also the MRI, the ultrasound, or how does that work? With the insurance, I don't know.
I believe tomosynthesis is usually covered. It's almost standard of care. It's not officially standard of care, but most of the facilities perform tomosynthesis on every patient because it did show improved sensitivity, so that should be covered. In terms of MRI and ultrasound, unfortunately, different companies, it's all individual. But again, in New York, hopefully starting January 1st, 2026, it should be covered because now we have a legislature supporting that.
We have one more question on that side of the room.
Hi, I'm Sandra Aline, and stage 4 metastatic breast cancer, ongoing chemo treatments right now. My question is, I have no kids, but my brothers have kids and they're under me. And my concern is my nieces. I have 3 nieces. One will be turning 25. Mm-hmm. So with me being the only one now in the family with carrying this disease, mm-hmm. I am more concerned, not about me anymore. I'm 67. And my concern is for the young females in my family. And I am so much into letting my doctor, I live in Brooklyn, I'm from Barbados, and my doctors run whatever tests, whatever research they can do to see if we can curb this with me, so that my nieces and all my female cousins wouldn't have to go through what I'm going through, because I know they wouldn't be able to withstand. I might be overstepping, but the faith and the prayers that you put up there, you have to stay prayerful and positive, and I would hope that that would happen for them. But I'm going to shut up quick. My 2 brothers, the suggestion would be for them to be tested as well, because my nieces, their mothers are making sure of that when they turn 25 to get the BRCA test, because the cancer came from my mom, my aunt, and my grandmother. So they're all gone. It's just, it came through me because I was the only girl, and from my mom. But my other cousins are okay.
And did you have genetic test?
Well, but
If you hadn't, it's normal, then
no, when I didn't, because I already was diagnosed.
You did.
And, you know, I just missed a couple months of a mammogram because I was checked every year after my mom died in 1983. And nothing,
Right.
and then, boom, it came up. So I'm just more, you know, concerned for the young ones.
Definitely, it's very important for their doctors to go through family history and possibly do genetic testing, because maybe there will be even more genes that will be identified.
Yes.
If you have it, it would be helpful to know. But if not, then they should be screened earlier.
When I was diagnosed, I was already stage 3, so, because it went straight to my lymph nodes. I was a strange case, I guess. I just wanted to make sure that my brothers
Right.
were under me and make
Right.
sure that they
So they should definitely have screening, good screening, and undergo risk assessment. Yes. Thank you. Thank you.
Again, if we don't have time to get to your questions, just in the interest of time, you can always find the speakers on the break or reach out to your post-survey where you can ask some questions there. Thank you so much, Dr. Rappaport, for sharing these detection advances with us. At this time, I'd like to invite Dr. George Zipoleis to the podium.
Good morning, everybody. Just took off the ID. I'm Dr. George Zipoleis. I'm a board-certified plastic surgeon and one of the partners at New York Plastic Surgical Group. It is my honor to introduce our next speaker, my patient, Kristina Thorne. Kristina's breast cancer journey began in 2020 during COVID, when the challenges facing patients were amplified by the complexities of navigating the pandemic protocols. Ultimately, she was diagnosed with stage 3 HER2-positive breast cancer. She had 16 rounds of chemotherapy and 16 rounds of radiation, followed by breast reconstruction. According to Kristina, her diagnosis changed her perspective on life. It taught her to listen to herself, to both pay attention to her body and reevaluate what truly makes her happy. Kristina has become a strong advocate for regular mammograms and makes sure to tell everyone how important it is to get one. She sees the glass half full and exudes warmth and positivity that you will see for yourselves. Please join me in welcoming Kristina.
As I sat there, coffee mug in hand, pondering on what I should speak on, the questions were clear. Where should I begin? Who do I want to reach? And how far-reaching will the sound of my voice be? And most of all, how can I be an inspiring voice to others? There were so many highs and even more lows throughout my journey, and to crunch them all into a short period of time is simply not possible. Therefore, I have chosen to share some of my more intimate moments. Never did I ever think I would be able to share these moments with others. However, purpose changes everything, and in my case, I always think, if I can positively affect even one person within the sound of my voice, I have met my goal. And so with this in mind, I will begin. I never realized how loud a quiet hospital waiting room could be until I found myself sitting in one, waiting for more scans to confirm the lurking suspicion of breast cancer. When you're scared and alone at the hospital, what do you do to kill time? You text your kids, of course, and this is what your firstborn sends you. I laughed, I cried, and immediately knew how he used humor to keep me uplifted. This is one of the first moments that will be forever etched in my mind. The silence of that waiting room was deafening. I remember staring at the walls, painted in dull colors, listening to the hum of the vending machines. It was so cold in there, and I was feeling the weight of the unknown settle over me. Maybe it was just out of boredom, maybe it was instinct. I'm not really sure, but I started documenting everything from that day on. The journey had begun. After years of dealing with a recurrence of pharyngitis, at 51, I finally mustered up the nerve to schedule myself for tonsillectomy. Not only did I decide to do this at the ripe old age of 51, I also scheduled surgery at the height of COVID. Surgery was both successful and painful, but it was all done. All I had to do was stay home and recover. 6 days later, still homebound and healing from surgery, things took a turn for the worse. The phone rang and it was confirmed. The results were in and I had breast cancer. With my 2 sons by my side, I was quickly thrown into a whirlwind of doctor's visits, countless explanations, port insertion, chemo sessions, surgeries, and the looming uncertainty of what was ahead. I was scared. No, if I'm going to be honest, I was absolutely terrified. There's really no sugarcoating that. All of a sudden, it was like I had gone deaf. I couldn't hear, I certainly couldn't process, and all that was logical was completely out of my reach. Nothing seemed to make sense. The treatments eventually began and were tough. Chemo left me exhausted and feeling like a stranger in my own body. I was broken. I didn't ask for any of this, I didn't want it, and I certainly didn't want to go through this process, but I did. One of the hardest days came when I had no choice but to shave off my beautiful silky black hair. It wasn't until this day that I realized how much my hair meant to me. All I remembered is being seated facing the mirror, my childhood best friend standing behind me, clippers in hand, as we both watched it all fall away. She smiled when I cried, I smiled when she cried. We stared at each other in silence, and now I was bald. It felt like something out of the Britney Spears saga, Girl Gone Bald. That moment was a brutal one because I'm naturally a private person, and suddenly I felt exposed in a way that I wasn't ready for. The bald head of a cancer patient speaks volumes. Another unexpected event that I still find surprising today is how much cancer would affect me mentally. I may be private, but most people that know me would probably call me strong-willed. However, this time, things proved to be different. It wasn't until another close friend pointed it out that I even realized it. "Christina, you've changed," she said. And when I asked what she meant, she said something that stopped me in my tracks. "You sound so angry." I hadn't noticed it, but she was right. The cancer had seeped through me in a way that I couldn't accept. My only outlet up to this point was anger, frustration, and fear. I hadn't realized that my personality had changed along with the rest of me. Cancer had now affected all of me. I knew that I would have to submit to this new reality. It just wasn't going to go away. Families and medical professionals, please always remember, even when a patient looks fine from the outside, a smile can hide so much pain. I promise you that your family member or your patient is battling something much bigger internally. No matter how many times I was reminded how strong I am or that I will be okay, the fear is real. And all I wanted to do was escape what felt like a sentencing. It's in the same fear that I somehow began shedding a part of myself. I'm guessing this was just part of the healing process for me. With no other choices available, I had nothing but time on my hands. Time to think, time to reflect, and enough time to remember what my once busy life had me easily forget. One of the things that came to mind over and over again was Psalm 46:10. Be still and know I am God. This journey truly taught me how to slow down, how to listen to my body, how to listen to my heart, and how to listen to that little voice inside of me. You know, the one that we're always ignoring? Yeah, that one. There were many days when I didn't think I'd make it, but I knew it was time to make a conscious decision to lean into my faith. I trusted that God would guide me to safe grounds again, and that is exactly what he did for me. I was led to some of the most incredible doctors in this field, doctors like Dr. Zipoleas. If I told you the story of how I found him, you honestly wouldn't believe me, but suffice it to say, he too was heaven sent. I met him at a pivotal time in my journey, a time when I was utterly dismayed by the lack of compassion, empathy, and simply put, humanity from others in this field. I had encountered individuals who seemed to move through their roles with a detached sense of duty, where genuine care and understanding were replaced by bureaucracy and indifference. The challenges I faced were not only professional, but deeply personal, and the absence of these basic human qualities weighed heavily on me. In a world that often feels transactional, Dr. Zipoleas brought an undeniable warmth and authenticity that restored my faith in doctors. He became a reminder that even in the most professional or seemingly impersonal settings, there's always room for empathy, and that those who lead with it leave a lasting impact. Dr. Zipoleas, thank you for being a great doctor and even a greater human being. My medical team guided me every step of the way, and I listened. Well, even when it took several attempts. I know, Dr. Zipoleas, I know, I'm hard-headed. But most of all, my medical team always took the time to listen to me. Together, we planned one day at a time, one treatment at a time. And now, here I am. I made it through what I would call the hardest time of my life. I've completed all of my treatments, and I stand before you today as someone who didn't just survive, but as a woman who is happy again. Through it all, life continued to bless me. With treatments and surgeries behind me, I was able to attend my son's wedding that same year. And then, a year later, I was given the best title in the world. I'm grandmother to our little princess, Georgina. I am filled with more love and gratitude than I could ever put in words because the blessings didn't stop there. Our family continues to grow, and we are now preparing for another wedding. Welcome to the family, Alex. I'm not saying that the journey was easy, but what I am saying is that by embracing the changes, I was able to overcome the fear and see the blessings. As cliche as it may sound, cancer tried to take so much away from me, but in the end, it gave me a new perspective. It gave me a new purpose, and it gave me a new appreciation for all the love and wonderful people in my life. So as I stand here today, I'm not just celebrating being cancer-free. I'm celebrating life's blessings, the highs, the lows, and absolutely everything in between. I never would have imagined I would be saying this back in the hospital waiting room in January of 2021. I couldn't even utter the word cancer, let alone talk about the intimate details of my journey. I am truly grateful for the opportunity to share my story. It is an incredible honor to walk in the footsteps of so many brave women that came before me. And as I close, I want to pay tribute to all the Pink Sisters that follow. Your fight does not have to be neat. It doesn't have to be pretty. Make this fight whatever you need it to be. Just please keep on fighting. Thank you.
Thank you so much, Christina. That was beautiful. And for being so brave, sharing your story, which you haven't done before. I know that's not easy, but everyone here appreciates that. As Dr. Adana shared earlier, developments and updates on detecting and treating breast cancer are happening all the time. Up next, we have Dr. Yelda Nouri of New York Cancer and Blood Specialists. Dr. Nouri will be speaking about biomarker treatments for breast cancer patients. Welcome, Dr. Nouri.
Good morning, everyone. It's really, really hard to speak after Christina. You were so phenomenal. I almost just want to pack up and say time to go home because that was just so incredibly amazing. When Christina was speaking, it really brought to mind something that I think about when I go into my patient's room, and that's a quote, actually, that my husband shared with me not too long ago, saying, "Action cures fear." And I think our job in the breast community is to go into every patient's room, be at these events, and really call to action things that are going to help treat patients, cure breast cancer, and alleviate fear. So we're going to talk a little bit about biomarker testing, and this is really a hot topic in breast cancer. And what I did was I divided up my talk to really kind of reach to everybody in the audience, early stage breast cancer as well as advanced breast cancer. Because the biomarker testing that we do for early stage is a little bit different than advanced. So I want to make that clear because oftentimes there's a lot of confusion about should my doctor be ordering this test or do I need this, and why did my friend get this test and why didn't I? So in early stage breast cancer, we focus on prognostic and predictive markers because we want to be able to tell our patients, what is your prognosis? How likely is your cancer to come back? And what are the percentages? You know, those are things we like to share, and those are the things that patients want to know from their medical oncologist. And in advanced breast cancer, two emerging treatments are, tumor genomic sequencing and the role of ctDNA, which is a super hot topic, and I know Dr. Rappaport touched on that in her discussion. So talking a little bit about the evolution of targeted therapy in breast cancer, this is what everyone's talking about in all of oncology: targeted therapy, personalized medicine. I'm happy to say that in good old breast cancer, we introduced tamoxifen. We started utilizing tamoxifen in the 60s, which is truly the first targeted therapy in breast cancer. It was approved in the metastatic setting in the 70s, just a little historical background, and it really revolutionized the landscape of the treatment of metastatic breast cancer. And the first clinical use of tamoxifen was actually reported in the British Journal of Cancer in 1971. So we kind of beat everyone to targeted therapy. And why are biomarkers so important? Well, biomarkers give us insight into how breast cancer cells work and function. And if we can figure out how they work, we can figure out how to kill them. We can assess the cancer's responsiveness to endocrine therapy, chemotherapy, and targeted therapy. And we can tailor therapy in breast cancer and biomarker testing to allow our oncologists to understand how likely the cancer is to behave and how likely our treatments are to actually work. And what are the goals of our molecular testing? This is a pretty busy slide, but really what we want to do is figure out what women really need chemotherapy, where we can avoid cytotoxic chemotherapy, and where overtreating women with chemotherapy is not beneficial. And we want to de-escalate treatment and perhaps intensify treatment in other situations. Current genomic tests do not predict an individual's response or need for adjuvant therapy based on presence of residual disease, but we're hoping to get more and garner more information about this. So when you're first diagnosed with breast cancer, super, super important, and I tell every single one of my patients before they leave the office, I want you to walk out at least knowing what your diagnosis is, if your cancer is being driven by estrogen or progesterone or HER2, and that's what this slide is basically saying. Always test every breast cancer biopsy with estrogen, progesterone, and HER2. A common question I get asked is, I have ductal carcinoma in situ, or DCIS. Why didn't they do HER2 testing? Well, we don't do HER2 testing on DCIS because at this point we're not using HER2-directed therapy. So it's good for your oncologist to really sort through, write down these nuances. And I tell my patients, I want you to walk into your plastic surgeon's office, your surgical oncologist's office, and I want you to be the smartest patient and know everything you need to know. You're going to dazzle them. Other important tests that we may see on our biopsy report, something called a Ki-67, and that's a marker for proliferation. So the higher the number, the more proliferative, or some patients ask me, is it faster growing? And higher Ki-67 can be a prognostic marker because unfortunately, those patients with a higher Ki-67 are at a higher risk of recurrence. Another emerging strategy, so this isn't quite commonly used on a day-to-day basis, but I think it's going to come up in discussions. And since my patients are becoming smarter and smarter and come in with data and literature, it's important to share this with them. But the concept of TILs, or tumor-infiltrating lymphocytes. And what we know is that having higher TILs in a biopsy or pathology specimen, especially in women with triple-negative breast cancer, is considered to be a good prognostic marker. So if we give patients preoperative therapy and the final pathologic analysis, if we're seeing a good deal of tumor-infiltrating lymphocytes, it means that we've done a good job and thereby eliciting an immune response, and those patients have a better prognosis. And which biomarkers can be used to tell if my cancer is likely to recur? These are called prognostic markers, and we perform this by doing genomic profiling. So some examples that perhaps some of our physicians or even our survivors or current patients have seen, tests like Oncotype, Mammoprint, Prosigna, Breast Cancer Index, or EndoPredict. Personally, as in my practice, I use pretty much exclusively Oncotype, and I do utilize Breast Cancer Index for my estrogen positive patients to determine whether they would benefit from 5 years of therapy versus 7 years of hormone blocker. And again, personalized medicine. Not every woman needs 5 years, not every woman needs 7 years. So we're really trying to individualize our treatment paradigms. RS Clin, this is another super, super important hot topic. If you're a breast medical oncologist like I am, this is something you're doing in the office every day. So when a patient comes to see me with an early stage breast cancer and they have an Oncotype report, we see that score. I take it a step further. RS Clin was developed as an additional tool that incorporates other factors that can determine prognosis in breast cancer, such as the grade of the cancer, the size, the age of the patient, and the planned hormonal treatment. So I sit with my patients, I plug in these additional numbers, it's a nice calculator, nice interface, and I'm able to really give my patients another level of security knowing whether or not chemo is indicated for them. Another type of genomic profile that some of you may have had done on your cancer is something called PAM50. That's another way to determine whether your cancer is what we call a luminal A or luminal B or basal-like, and what exactly does that mean? Just to kind of make it simplified, luminal A are our traditional cancers that are driven by estrogen. These tend to be more favorable and carry the best prognosis. Luminal B tend to behave a little more aggressively than luminal A, and this is really our HER2 positive patients. So we incorporate luminal B patients into the HER2 category. And then basal-like are very, very aggressive, and these are our triple negative breast cancers. So let's move on to biomarker testing in advanced disease, because this is a super hot topic, and I can't tell you, at least once a week, a patient will come into my office and say, are we ready to do ctDNA? And what I tell them is, we're getting there, we're just not quite there yet, not ready for prime time. So what's a liquid biopsy, and what is ctDNA? A liquid biopsy, and this is super exciting and amazing about breast cancer, so cutting edge. Whereas we used to take a piece of a tumor, let's say lung cancer or rectal cancer, and we look for mutations like PDL1 and other targets. In breast cancer, what we find is that liquid biopsies, which are done from your blood, provide a very active and basically moment by moment analysis of what mutations are driving your breast cancer. So we draw a tube of blood, we send it off to a company called Foundation or Guardant, and we're able to come back and target actionable mutations like ESR1, PIK3 mutations, PTEN, and AKT mutations. And within the last 2 years, we have several drug approvals where we can use oral therapy instead of intravenous chemotherapy for women with these mutations. Now, I will tell you, these are limited to women with estrogen-dependent metastatic breast cancer, but still really exciting. And if I can delay my patients from needing chemotherapy in the metastatic or stage 4 setting, it's a win-win. So how is that different than ctDNA? Because liquid biopsy is something we are using on a day-to-day basis. ctDNA is a little bit different. So ctDNA actually looks at the proportion of cancer DNA in a patient's blood. And as Dr. Rappaport alluded to, in current clinical trials, we have some phase 3 trials going on, we're looking at ctDNA as a surrogate marker for how a patient's responding to treatment in the metastatic setting. So ctDNA is not quite ready for early stage, and in fact, we're not really sure how to interpret the results. So I think what I tell my patients is it's going to happen in the next couple of years, and I promise I'll be the first person to tell you about it when you come in for your follow-ups. But ctDNA is also considered a prognostic marker, and in some of the studies that it's being utilized in, we can really see responsiveness to certain systemic treatments. There is one type of ctDNA testing that is called tumor agnostic. It's done by a company called Signatera. And basically, they take a piece of the patient's, it's pretty cool actually, they take a piece of the patient's cancer, and they prepare it in a lab and they create almost like a signature, and we're able to track that signature in the patient's blood to assess for treatment response. So definitely going to be coming up in the near future. So this is just a slide. I'm not going to go through all of it, but just really just shows you in the NCCN, in breast cancer, we have all these amazing targets, PIK3, ESR1. We're even targeting mutations like such as BRCA1 and BRCA2, and we have oral treatments, something called PARP inhibitors. So I think, in my opinion, and I think this is standard of care, but any woman with metastatic breast cancer should absolutely have germline testing, because if you carry either a somatic or germline BRCA mutation, your oncologist has the ability to use a PARP inhibitor as part of your treatment. And oftentimes, if we give PARP inhibitors earlier, they work better. So this is key. This is important information. So as educated, breast cancer survivors and family members and support system, it's important for you to walk in and say, Dr. So-and-so, am I getting germline testing? Am I getting a BRCA test? So important to share that with your provider. So again, these are the biomarkers. These are the targets for drugs. We have new drugs called RET inhibitors, SERDs, selective estrogen receptor degraders, and we're even using immunotherapy. Immunotherapy drugs like Keytruda or Opdivo that target PD-L1, we see it all over the news. We used to joke around in breast cancer, we were pretty late to the game, but in recent years we're using immunotherapy for the treatment of triple-negative breast cancer. And we're also using things called drug antibody conjugates that have really changed the landscape of breast cancer. In addition to liquid biopsy and ctDNA, there's another type of genomic profiling we do, which is called tissue-based testing. This is something I often will do at the time of a diagnosis of metastatic disease. It's a little bit different than liquid because your tumor or a piece of your tumor that's in a pathology lab is not going to change over time. So oftentimes if I do tissue NGS or tissue-based testing, I'm getting basically a static picture of the mutations that the patient harbors. I find this helpful because in first-line treatment for metastatic triple-negative, we really need to assess PD-L1 because you want to use immunotherapy in the front line. So I do get tissue-based testing, but upon progression, that's when we go to our liquid biopsies because it's very cumbersome and often, painful for patients to keep on getting rebiopsies. And really, what's the future? What's the future of precision medicine and targeted therapy in breast cancer? Eventually, our goal in the breast medical oncology field is to de-escalate and remove, hopefully, cytotoxic chemotherapy from our treatment paradigms altogether. What we want to do is identify mutations. We want to identify what receptors each patient expresses so we can give them treatment that's going to work, but limits the potential future side effects. I want to thank you guys for allowing me to come and speak. I know it's a little bit of a, drier topic in terms of what medical options are available, but I hope this provides some insight into the future and allows patients to potentially ask great questions at their next visit with their oncologist. Thank you. Thank you.
Do we have any questions for Dr. Nouri?
Good morning, doctor. My name is Bianca Robinson, and I'm here in support of my friend Selma Jackson. My question is there basic questions that women should ask during and after their mammograms? Because typically I walk in, have my mammogram, and then I receive my results.
That's a wonderful question. So I think, first of all, when you get your screening breast imaging, the most important thing is that you feel comfortable and safe, that you express to your technician if you're, having, discomfort at a proportion. I think per se there's no specific question, but if there's something that is making you feel uncomfortable, or let's say you have a breast concern, that is definitely something you want to bring to the attention. When I get my screening breast imaging, the nurse who's kind of triaging me or bringing me into my exam will ask if I have any concerns, any updates, any changes. So I think being as vocal as possible is super, super important. So if you feel like something, you need to discuss, absolutely, bring it up. We had a question?
Can I ask a question? I don't think I'm sorry. In regards to the markers, now, are they basically like a best practice? Are they part of the guidelines? Because I definitely noticed in a recent retreat I went to that women, depending on who they go to, have a difference in treatment.
Absolutely.
And not only based on their type of cancer, but there just seems to be a definite variation.
A disparity, right.
So I'm just kind of wondering, are those markers and things like that part of a typical plan? Or do you have to go and ask your oncologist, can you test me genetically, these genomes and things like that?
Sure. No, and I actually get that from a lot of patients who maybe come to me as a second opinion, or I'm providing a first or second opinion. I think there are definitely some challenges in the breast community. I think if you do breast cancer every day and 90+% of your patients, yes, you are going to be doing potentially more advanced testing. But I do think that in the early stage, I'm just going to divide it up into early stage, best practice standard of care, and any pathologist who's in this room knows that you test for estrogen, progesterone, and HER2. That is mandatory. And then you do reflex testing to determine if a patient's FISH positive, if they have an equivocal HER2. So every woman should have an answer when they're seeing their surgeon or their medical oncologist. Is my cancer estrogen, progesterone positive? Is it HER2 positive? Is it triple negative? That's standard. Every woman should know that. And I don't think that should be, questioned at all. Then when it comes to germline testing in the advanced setting, unfortunately I hear what you said is that not everyone gets germline testing at the diagnosis of metastatic disease, but they should. So even though we do rely on our doctors, sometimes being an informed breast cancer patient is so important. And I know so many of our survivors, so many of my patients belong to support groups, Facebook groups, and it's nice because it's a nice opportunity to share that information. But yes, unfortunately, sometimes you do have to kind of go to your doctor and say, should I be getting this test? Should I be having a liquid biopsy on progression? So yeah, I think we all have to be more informed and educated as a community.
Dr. Nori, I have another question for you over here.
Good morning, everyone. My name is Marcia Jackson. I was diagnosed with metastatic breast cancer in 2023, May of 2023, and my doctor told me that chemo, radiation, and surgery wasn't an option. However, I recently had a liquid biopsy and a PET scan 2 weeks ago. My doctor called me yesterday to inform me that he's going to start me on a liquid,
pill?
Pill, yeah, a pill chemo. What questions should I be asking my doctor once I go in? What caused the change from me not able to have standard of care? Now I'm able to have the pill after doing the liquid biopsy.
Great. So first of all, kudos to your oncologist. I'm happy that people are doing liquid biopsies on progression. I think your question is kind of two parts. The first part of your question is, should we be doing radiation surgery in women who have advanced disease? And what do we mean by advanced disease? Unfortunately, some women, at the time of their diagnosis, when they're first diagnosed, unfortunately, we find disease outside of the breast or armpit, maybe in the bone or the lung, and we biopsy it, and it's unfortunately breast cancer cells that spread somewhere else. In that situation, it's a very hard discussion, but yes, chemotherapy, radiation, and aggressive surgery in the metastatic setting has never been shown to improve survival. And in fact, and again, this is case by case, because I'm sure all of us who've treated patients with stage 4 cancer have had, patients that we have done more aggressive things on. But generally speaking, we try and do less toxic treatment because we know we're in this for the long haul. This is a marathon. This is not a sprint. So I agree with that. Statistically, you are not going to improve a patient's outcome by doing surgery or removal of the breast cancer in stage 4 disease. The next part of the question is, how come you can do an oral therapy now? And that's the beauty of liquid biopsy. Cancer is ever changing. The biology, the genomics, the estrogen, progesterone status, especially in breast cancer, it changes over time. Breast cancer is a dynamic disease. And basically by getting a liquid biopsy at this juncture, now your cancer now has this mutation that we can target with one of the great new therapies that have been FDA approved. I think what's important for you to ask your physician is, what is that mutation? So we definitely want to know. And what you want to know are, what are the side effects I should expect? Because a lot of these targeted therapies have very, very specific side effects. And I think you should ask, how long do you think, or in the trials that led to the approval for you to recommend this drug, how long do you think I'm going to be on this treatment for? And I think those are the important things you should ask. So kudos, and I'm happy that you're able to take a new targeted therapy. That's awesome.
We just have one more question back here. Hi. I was diagnosed with stage 3 breast cancer in 2018 and then re-diagnosed with metastatic breast cancer last year. I did have a liquid biopsy, and I do have the ESR1 mutation. I'm currently on Kisqali, and I am proud to say I've been no evidence of disease in my last PET scan, so I'm very happy about that. Thank you. My question is, since I do have the ESR1 mutation, is it possible that it will mutate again to possibly the PIK mutation, or how often does that happen? Does it happen often?
Absolutely. So great question. So a concomitant ESR1 mutation with a PIK3 mutation is actually very common. I have patients in my own clinical practice, and oftentimes it's tough because, actually it's a good thing, because I'm like, do I give them an ESR1 target? Do I go for a PIK3 targeting agent? And typically what I do in my practice is, if you're doing well on ribociclib or Kisqali, you're going to ride that wave as long as you can. Upon progression, now we have the option of giving you elacestrant or Orserdu, and following that we can give you capivasertib. Awesome. However, what I typically do is, if a patient is doing well with no signs of impending failure of, God forbid, one of the organs like the liver or the lung, I tend to go to elacestrant, because it has less chemo-like side effects than the PIK3 inhibitors. But I would also re-biopsy you at the time of progression, and hopefully that's not for a very, very long time.
I actually have another sidebar question.
Sure.
So since I'm doing well on the Kisqali, and hopefully I'll be doing well for a very long time, what prompts possibly doing chemotherapy again?
Great question. So once we have exhausted all of our targeted options, we then move to what we call more traditional chemotherapy. The good news is there was a pivotal trial, the Destiny Breast 06 trial, that was just discussed at our annual conference, ASCO. And what we now know is that we don't have to go to chemo after our oral targeted agents. We can now utilize a drug antibody conjugate called Enhertu. So what's really exciting for me is now I'm delaying the time to traditional intravenous chemotherapy even further with the ability to use this drug antibody conjugate. So I hope that hopefully in the next couple of decades, we're not using chemo at all for breast cancer patients.
Awesome. Thank you so much.
Thank you, Dr. Nori. That was fascinating. Breast reconstruction is available to all women diagnosed with breast cancer, and there are many types of reconstruction options. Breast reconstruction is about more than physical appearance. Many women who have had reconstruction can speak to the fact that it made them feel whole again, which carries tremendous benefits for both mental and emotional health. At this time, I'd like to invite Dr. Barry Douglas to the podium. Dr. Douglas is a board-certified plastic surgeon and partner at New York Plastic Surgical Group. He'll be moderating a panel discussion with his peers.
Good morning. It's an honor to be here to speak about the always evolving topic of breast reconstruction. And I will be with three of my partners to discuss some very interesting new information that'll be pertinent to a lot of the people in the audience. I've been with the Plastic Surgical Group here for 33 and a half years. For most of my career, it was known as Long Island Plastic Surgical Group, which was affectionately called LIPS, L-I-P-S. As we expanded to various geographic areas, it became New York Plastic Surgical Group, which is pronounced NIPS. Don't forget the G, please. If you Google NIPS, it's a porn site. With our strategic planning to acquire more practices and expand, you could think of it going to the Northeastern Plastic Surgical Group, which would be NEPS, going further, Western Hemisphere Plastic Surgical Group, to be WEEPS, and finally planetary takeover for EEPS. So I'd like to introduce my three esteemed colleagues, and they can come up here and take the stand. First, Dr. Matthew Kilgo. Dr. Kilgo received his medical degree from the University of Chicago, Pritzker. He completed his plastic surgery training at the Indiana University and received a subspecialty training as a fellowship in cancer reconstruction at Memorial Sloan Kettering, which interestingly has the initials MSK, which is exactly Dr. Kilgo's initials. Dr. Natoli, Dr. Noel Natoli, please. Dr. Natoli obtained her Doctor of Medicine from Upstate Medical in a university in Syracuse. She wanted to complete residency in plastic surgery at Penn State Hershey, and then to U of P in Philadelphia for microsurgery reconstruction. And then I'd like to introduce Haritha Veeramachineni, who is affectionately known as Dr. Veera. Dr. Veera completed medical school at Vanderbilt at Nashville. She completed her plastic surgical training program at the University of Southern California, and she is currently a president of the New York Society of Plastic Surgeons and is very active with state and national advocacy efforts to improve healthcare access. So it is an honor being here, and we will start discussing three very interesting topics of breast reconstruction, one with implant-based, one autologous, and also something relatively new, which is nerve grafting. So I will start with Dr. Veera regarding nerve grafting. So please tell me, what is nerve grafting and breast reconstruction?
Okay, thank you everyone for coming today. So nerve grafting is a newer technique we have in breast reconstruction where we can help restore some of the sensation to the skin flap and the nipple during these cases. This can be done either with autologous tissue, so when we use tissue from usually a patient's abdomen to restore the breast, and it can also be used during implant-based reconstructions. So I have a few slides I can go through that illustrate how we do the surgery. So anatomically speaking, the nerves that provide sensation to our breast are going to come from mainly the lateral intercostal nerves. So it's the 3rd through the 5th nerve. So those are those yellow squiggly lines that you see off on the side of the breast. During a mastectomy, this would normally run through the breast tissue towards the skin. So these are all removed during a mastectomy procedure. However, at the time of mastectomy, we can dissect some of these out and preserve them. And then later on, reconnect these nerves, sometimes directly into the skin itself if you trace out a long enough nerve, but we can also use a nerve graft as a bridge. So this is actually a picture of a case I did with my good friend, Dr. Jana Deitch, last week. I had one of our nurses stop and take a photo. So those 3 little strings that you see on the side are the 3rd through the 5th intercostal nerves. So this was during a double mastectomy procedure where we aimed to preserve the sensation for the patient. And these are some of the nerves that were dissected out. And so if you go to the next slide, what we do is we connect one of those nerves to a piece of nerve graft. Nerve graft is a cadaveric nerve graft, which is harvested usually from someone's nerve in their leg, and all of the cells and all living tissue are removed. So this is just a prepackaged nerve graft that we can keep around at hospitals and order for these cases. So you can see that long spaghettini-looking thing is the preserved nerve graft. So we're going to connect it with microsurgical techniques to the patient's nerve, and then over time, the patient's nerve fibers grow at about 1 millimeter a day through that nerve graft and can eventually reach their end targets. So next slide. So we can take the other end of that nerve graft and connect it either directly to the skin or to the underside of a nipple in a nipple-preserving reconstruction and hope to restore sensation there. Thank you.
In terms of the sensation, what would a patient be expected to get in terms of the quality?
That's a great question. So at baseline, many of you know in this room, after a mastectomy, initially the skin is extremely numb. Studies have shown that over a year or two, some peripheral sensation is usually restored on its own, but it's not very sensitive. The studies that have done nerve grafting have shown that at a year's time, especially when the nerve graft is hooked into an autologous flap tissue, the sensation using these techniques is superior, but after a year's time. And it's not as sensitive as it was before, but it comes pretty close in the small studies that have been performed.
Someone that's scheduled to be having radiation as part of their treatment, how would that affect that?
So far, the studies that have been done are anywhere between 50 and maybe 170 patients, and there hasn't been any looking specifically at radiation, but so far it is not a contraindication.
Excellent. I'm going to go on to Dr. Noel Natoli, who's going to be discussing topics of autologous reconstruction. Dr. Natoli, who is a good candidate for autologous reconstruction?
So patients who are recommended for it are patients who, aren't candidates for the implant-based reconstruction, and certainly a large portion of this is it's a woman's choice. So every patient should be educated on their options, whether it be implant-based or autologous-based reconstruction. And not all women want breast reconstruction. Some come to me for aesthetic flat closures. So that's part of the mandate and legislature that all women be offered and be educated on their options, because not every reconstructive surgeon that sees a patient is able to offer autologous reconstruction. Patients that we recommend even greater for it are patients that have failed implant-based reconstruction, or patients that are anticipating radiation or have had radiation, in a recurrence type setting and are going to do a little better with in autologous versus implant-based reconstruction.
So what are the most common forms of autologous reconstruction that you perform?
Yes, so most commonly, if we can use the belly, we use the belly fat because it's going to be the softest, the most robust. And I have women come into the office and ask, well, why not use my gluteal fat? I'd prefer that. That type of a case is longer because they're not geographically in the same area. So if we're doing it at the same time as breast reconstruction, most of the time we do it one side at a time because we then have to turn the patient, get the donor site, and bring it back to the breast. And also then I invite the women to grab your belly. It's nice and soft. It feels similar to your breast tissue. And grab your bum, and it's honestly firmer. It's just, it doesn't give you as soft of a breast reconstruction. Other areas that we use for harvest, other than the gluteal perforator flaps, are tug flaps, which is the inner thigh flap, and a pap flap, which is the outer posterior thigh flap. Again, geographically distinct. One of the problem with the thigh flap donor sites is often it doesn't yield as much tissue, and so often in these patients that either have had surgeries on their belly that preclude them from being a donor for a DEEP, these other reconstructions may need to still have an implant on top of it, which is kind of a bummer.
So with the deep inferior epigastric perforator flaps being the most predominant form of autologous reconstruction, the patient, let's say, is in her 40s, she's an avid tennis player, and she wants to know about the effect of donor site morbidity.
Yeah, so I would tell that patient that obviously we are using your belly as a donor site, so you can expect some weakness. Even when we dissect out the nerves and preserve them, we are going through that tissue, and so there is some abdominal wall weakness. If we're able to do a pure deep flap versus what we call a muscle sparing or a pure tram, or in last resort, a pedicle tram flap, then we're using increasing amounts and dissecting increasing amounts of their rectus muscles, and those are your six-pack muscles, the muscles that help you get out of bed, sit up, and your core strength for all those activities, such as tennis.
Doctor, do I need drains for this procedure?
You're not a good candidate. Yes. I tell my patients that I anticipate a drain at each breast site and 2 drains at the belly, one on each hemi-abdomen or whichever donor site we're taking from.
What are some of the potential risks of doing microsurgical reconstruction?
Sure. So I tell patients their greatest risk is within the first 72 hours. We keep them in the intensive care, a monitored setting. Sometimes it's a step-down unit, so that they can have the flaps checked, whether that be by Doppler, Vioptics, whatever, T-stat, what we have now. And because the greatest risk of having a thrombosis where these little small vessels or reanastomose is in that first 72 hours. And most of the time when there's a problem, it happens on the table. We're able to fix it. We closely monitor these women. But like surgery anywhere else, risk for bleeding, infection, fluid collection, seroma, hematoma, need for a take back, risk of asymmetry, scarring, and the donor site problems such as wounds opening, scarring at those sites in addition.
And what type of revisions or associated procedures are typical?
Yeah, we like to nail it out of the park, like baseball fans in the first surgery, and often we can, but very often these patients require a revision for symmetry. If we're doing the nipple reconstructions, usually that's a second stage. If there's some asymmetry of the breasts, or there's dog ears on the side, or need for fat grafting for additional volume.
Thank you very much. Dr. Kilgo, so tell me some of the new technological developments with breast implants.
Yeah, so there's some very exciting news, I think, when it comes to breast implants, because for the first time in almost a decade, there is a new implant, which I think is very innovative, that's been approved for use in the United States by the FDA. When I say recently, it's been in the past 3 weeks, less than a month, and these products should be out for use within the next couple weeks. Having said that, the FDA has authorized use for cosmetic breast surgery only at this point in time, but I'm hopeful that as the data comes out, that the reconstructive indication will follow soon after. Whenever there's a new medical device on the market, like an implant, I think it's important to ask, is this product going to improve patient outcomes compared to what's on the market currently? And I think the preliminary data is very promising with regard to, in particular, what's called capsular contracture. Now, capsular contracture is a complication after breast implant surgery that's all too common. When we put a breast implant in, normally there's a thin layer of scar tissue that surrounds it, and that's a normal process. With the capsular contracture, that becomes more aggressive, and the capsule thickens, and it can become symptomatic. The implant becomes firm, it can change position, change shape, and in the worst case scenario, it can be painful. So it's an all too common problem, and unfortunately, we don't have great ways of dealing with it. Now, one of the common denominators of what causes this is inflammation around the implant. And one of the factors that impacts that is the outer surface, or what we call the texture of the implant. So traditionally, implants are either smooth or they're textured. The texture meaning it's a kind of a rough surface. And historically, textured implants have been associated with lower capsular contracture rates. The problem with textured implants, and we've discussed this in years past at the Breast Summit, is that they are associated with a very rare type of cancer called breast implant-associated large cell lymphoma, so their use in the United States has been really limited. What's really interesting about this new implant is it's got a very innovative outer shell. It's called nanosurface, so it's extremely finely textured, so much so that it's considered a smooth implant by the FDA. But the outer surface was designed specifically to reduce that inflammation. And studies have demonstrated significantly lower rates of capsular contracture when you compare them to the products that are on the market currently. Now, most of that data is from cosmetic breast surgery, and the data thus far on reconstruction is fairly limited. There are a couple of smaller studies out of Israel with patients like numbering in the 150s to 200s that have shown promising results with regard to capsular contractures in patients who had breast reconstruction with and without radiation therapy compared to what we would typically expect. So I think time will tell whether this will be a product that will help us sort of deal with an all too common, very problematic complication.
So the problem with the large cell lymphoma that is obviously very rare, but patients that do have implants, how can they know that they're okay, or what would be the first symptoms that they would see that would be problematic?
So I think it's worthwhile maybe reviewing, breast implant-associated large cell lymphoma. It's a cancer that occurs in that capsule around the implant, and it's almost exclusively associated with textured devices. It has occurred in both patients who've had reconstruction and patients who've had cosmetic breast surgery. It's a very treatable disease. The treatment is removal of the implant along with the capsule, called an en bloc capsulectomy, and the vast majority of patients are cured. The symptoms, the most common symptom is breast swelling. It's not subtle. It usually happens fairly rapidly. It's caused from fluid around the implant within that scar capsule. Other symptoms could include lumps, pain, change in the shape of the breast, asymmetry. Any of those symptoms should prompt someone to go see a plastic surgeon if you have a breast implant in place. They typically don't occur for about 8 to 10 years after implantation.
In your practice, do you prefer placing implants above the muscle prepectoral or under the muscle?
So that's really on a case-by-case basis, and I tell patients that I make the decision in the operating room, and it's based on, number one, how the skin looks and how the soft tissue coverage is over the implant. If it looks really healthy, I'd be more willing to put it above the muscle. Thinner patients tend to not do as well because most of those patients require a little bit of fat grafting after the surgery in order to thicken that soft tissue covering so you don't have visible rippling in the future. And then there's also the issue of where is the tumor located. If it's located very close to the chest wall, I'll put it below the muscle.
Just explain a little bit about the fat grafting, how that helps the outcome.
Fat grafting is a secondary process that we do on quite a few of our patients. When we do a breast implant reconstruction, the breast tissue is gone, and what you have is an implant with skin and fat covering it. So and oftentimes there's areas that are sort of what we call contour irregularities. So what we do secondarily is liposuction of certain areas of the body. We purify the fat and then inject it into those areas to thicken the soft tissue coverage and improve the aesthetic appearance of the breast.
Dr. Veer, when you're doing breast reconstruction, and obviously the main part is the aesthetic ability to reduplicate what has been taken away, How do you deal with people that have, let's say, adverse scarring, thickened scars, hypertrophic scars, red scars?
That's a great question. I think the best way to improve upon scarring is meticulous closure techniques, which all of us employ as plastic surgeons. So a mastectomy can be anywhere from a 1 to 2.5 hour procedure. So taking care of the skin during the mastectomy is the most important. Making sure the skin edges are healthy and closing them under low tension and with meticulous technique really does improve our scarring. But afterwards, what we can do is employ silicone scarring therapy. That has the best evidence-based research in terms of topical applications after surgery. Mederma is okay, but any type of silicone therapy afterwards is the best. And for patients who have hypertrophic scarring, we can also inject steroid directly into the scar to help it.
Okay. Dr. Natoli, when you're doing autologous reconstruction, do you also add cadaver tissue like alloderm or something?
Most often not, but in revisions often. It's kind of unusual to do it for primary autologous reconstruction, but I'll tend to use it in those cases if I'm putting in autologous reconstruction for the primary, if it's a delayed reconstruction, and I need to work on reconstructing the IMF and someone who's radiated on one side. I would say rare, maybe 10% of the time, but can be used at the same time safely.
What about mesh for the donor sites?
Mesh for the donor sites?
Just reinforcement of the core.
I know. Oh, yes. So for the deeps, it depends on their muscle laxity on an abdominal-based reconstruction. Sometimes we're using a permanent mesh to reinforce it. If it's a patient who's got a lot of laxity and we do a pure deep on both sides, often with your primary closure, we could do that alone, but we'll often put an underlay as well, for sure, but not an alloderm in that situation.
And Dr. Kilgo, for patients that have had implant-based reconstruction, how often is it where there's just an unsatisfactory result, either because of animation or the skin just doesn't redrape correctly, that you have to convert to autologous?
I would say primarily not that common. If patients have been radiated, that's when I see most of the issues with implant-based reconstruction, because capsular contracture rates are significantly increased in that setting. And implants just don't do as well in the face of radiation therapy when compared to autologous tissue.
Also with implant-based, when the skin flaps are relatively thin, does that limit your ability for nipple areola reconstruction in terms of options?
It does, certainly, particularly in a patient who has a prepectoral implant. It's becoming much more popular in those cases to do three-dimensional tattoos, and we have a nurse here, Kristin, who works with us, who's phenomenal. She's an artist, and she does amazing three-dimensional tattoos. So a lot of my patients are opting for that now.
Excellent.
Kristin's actually not in the vendor area
she is.
today.
Yeah, you should all stop by and see her work. It's amazing.
So I'd like to open up the floor to questions to the panelists.
We just have time for a couple of questions. Anybody on this side? Somebody back where? Oh, okay. Come in.
So, can you get some of those treatments as far as the scarring and the nerve correction 3 years post-mastectomy that wasn't offered at the time of your surgery?
Just to clarify, I believe you're asking if the nerve grafting can be done 3 years after a mastectomy?
Yeah.
So there has been no data on that. It certainly can be attempted. All of the cases that we have good data for are done at the time of mastectomy. However, there are some examples of cases done usually within the first 6 months or year after the mastectomy, so it's usually during a revision, or if the nerve graft was not possible at the time of, say, tissue expander placement, one can go back maybe a few months later, attempt to find the nerves on the lateral chest wall and reconnect them with a graft. Historically, because there's such little data, they have not been shown to be as effective. Also, because of the extensive scarring that takes place after the surgery, it's really difficult to find those nerves on the chest wall to perform that procedure. So I would say 3 years later, it's most patients would not be a good candidate for this.
We have one other question back here.
Hi. Back here. So my question is for the gentleman on the end. So what is the brand name of that implant that's coming out? I've had more contractures than I can count. So I'm just curious. So if I happen to have another one, then possibly I can recommend that implant.
Yeah, so it's called Motiva. And currently, again, it's only approved for cosmetic purposes, but as plastic surgeons, on a case-by-case basis, we can use these implants for reconstruction as what's called an off-label indication. So Motiva is the brand name, yeah. Sure.
We have another question over here.
Thank you. I was just wondering what you recommend for implant reconstruction. Is MRI better at the 3-year mark or ultrasound?
So MRI is definitely more sensitive. There are sometimes issues with insurance coverage, and they oftentimes ask for an ultrasound first. The current FDA recommendations, by the way, are 5 to 6 years now after implantation, and then usually every other year after that.
Oh, great. Thank you.
All right. One last question on this side of the room.
Good morning. You had mentioned that you work with a nipple tattoo artist, and I read that as of October 1st, Governor Kathy Hochul put into law that you cannot your insurer can no longer deny coverage for a 3D nipple tattoo, but that it has to be done by a physician. Not a nurse practitioner or PA. So I was wondering if you have any other color on that.
So yes, the New York Society of Plastic Surgeons actually does a lot of legislative work, and we did in fact support this bill. So the bill is that yes, it's going to be covered by insurance, but it has to be done as part of a physician's practice. So a nurse practitioner or a trained medical esthetician or a PA can certainly perform the tattooing, but it has to be under the guidance, supervision, auspices of a physician practice.
Got it. Okay, that makes sense. Because as you know, I don't know if you're familiar with Vinnie Myers, who pioneered the procedure. So obviously he's kind of rogue, and I know he does have some privileges. But if there's anyone in this room who's aged 18 to 39 and has been diagnosed with breast cancer or has a genetic mutation, has BRCA, we fund medical, beauty, wellness, and educational services for women diagnosed. Thank you. We are from New York City, and thank you to Dr. William Sampson for referring us today to come.
What's the organization name? That organization is 5 Under 40. That organization is 5 Under 40. 5 Under 40 is, yep.
Okay, thanks everyone.
Next on the agenda, we will be discussing something I think everyone is going to be interested in, on top of everything else that we've discussed today, which has been really illuminating and educational and fascinating. We're going to be discussing skincare and cancer treatment. I'd like to introduce medical esthetician Stacey Sager of Deep Blue Med Spa.
Hi, good morning, everyone. My name is Stacey Sager. I am one of the medical estheticians at Deep Blue Med Spa. So,
At Deep Blue Med Spa, our providers not only work alongside our very talented physicians who support us with patients, and they also help us with our treatment plans. I was contemplating on whether or not to share my little story today, but I decided I will. I myself did go through a little scare about 1.5 years ago, and I have to say I was very blessed to have Dr. Donna help me through this. At Deep Blue Med Spa, what sets us apart from everyone is having these physicians back us. We're overseen by New York Plastic Surgical Group. So what makes us different as a medical esthetician? With myself, I have over a decade long with experience in cancer care. We do medical grade skincare as well as things as microneedling, chemical peels, facials, laser treatments, dermaplaning, and much more. Chemotherapy, radiation therapy, and cell or bone marrow transplants affect rapidly growing cells, such as those in cancer patients. The skin happens to be the largest organ in our bodies, but it's constantly renewing itself. When patients are going through any sort of chemo or radiation therapy, their skin becomes compromised. What happens when your skin becomes compromised? We develop things as rashes, edema, which is swelling, erythema, which is redness can happen. I did put a little slide in there with some other things, the epidermis, the dermis, which I don't want to get too scientific because I'm trying to keep it as brief. But what usually gets affected is the epidermis, which is the outer layer of the skin. This is where everything tends to happen. When my patients come in, I usually tell them what's happening can take a very long time to resolve itself. The things I want you to refrain from doing is using anything with fragrance, chemicals in it, acids that might further irritate it. You want to avoid hot showers, dyes, pools, hot tubs, saunas, using makeup. Instead, what you want to do is wear things such as SPF. Make sure you're babying the skin. It's like damage happened to the skin. So therefore, we want to make sure it's well-nourished, hydrated. I did create a basic skincare regimen here, which I typically go through with my patients. Gentle cleanser, hydration, such as hyaluronic acid, is safe to use. I love our line, our Pro Blue line, that we have a deep blue, because it happens to be one of the lines that are paraben-free, as well as sulfate-free, dye-free, and fragrance-free. So some of the things that we do offer at Deep Blue Med Spa to help our patients, we do offer complimentary visias, which you can come in and consult with any of our providers. We do offer gentle facials as well. And going back to what you shouldn't be doing, anything invasive to the skin. So this is the time I'm going to say refrain from the microneedling, refrain from the lasers, and even massaging the skin as well. If you do have someone like myself who's cancer certified, this is where you would say to them upon consultation that you are going through some sort of treatment and ask for their guidance. So we are giving away at our table today the phytocorrective serum, and I know many people approached me and asked me what is in there. These are all botanicals, so it is safe to use it. And I would be more than happy to consult with anyone who had any questions or concerns about skincare while undergoing any of these treatments. Did we want to open up to any Q&A?
Does anybody have any questions for Stacey Ann about skincare while undergoing treatment or post-treatment?
No.
Oh, we do.
Go ahead.
Leave it to the reporter to ask the question. What type of skin conditions do you see when patients are undergoing therapy?
So typically when they do come in, they are irritated, very sensitive. So they can have rashes, that I can visibly see, and sometimes the underlying sensitivity can be hard to detect. So this is when I would take that opportunity to do a Visi on them, because that Visi really reveals what's going on underneath, things I cannot see with the naked eyes. Sometimes they're using things that they shouldn't be using, or someone recommended, and word of mouth, and then I have to look through the list of ingredients for them. That's why I always suggest medical grade skincare, which is what we specialize in.
And I'm sure people that come to you, they feel better. They probably think, oh, I don't really need this treatment. But when they leave, they realize, oh, I feel so much better.
Correct. I feel like with patients, again, it's hard. It's very hard because they're going through all this and they have a rash or they have dryness and they're like, okay, I'm going to go get Cetaphil or CeraVe. No offense to that. But sometimes they need a little bit more. They need the guidance of a professional, and that's what we're here for, to support them. And again, because we have such a great group of physicians that we work with, we can call them and say, hey, I have a patient that this is what's happening, and we could refer back to them. But at the end of the day, I always suggest checking with your individual providers, of course.
Okay.
Can you tell us a little bit about when it is actually safe to start doing some of those treatments?
So this is when I send them back to their provider. I will guide them with skincare, but when it comes to actual invasive procedures, I'll say, I think it's a good idea to wait a couple months after, but please check with them before coming back to us. And sometimes I would even ask them to honestly get written consent just, to make sure.
Stacey, over here, we have one more.
Mm-hmm.
Hello. Thank you so
Hi.
much for what you're doing with the cancer patient, because at that time they feel so vulnerable, and to make them feel prettier and give them some glow to their skin. But my question is, do some of the treatments that you provide are covered by insurance, or do they have to pay out of pocket?
So unfortunately, to my knowledge, our procedures are not covered by insurance.
Okay, thank you.
You're very welcome. Thank you so much for having me.
Thank you, Stacey Ann. I'm sure it's like with anything for women that we're always busy, we're going through a lot, we don't think to take the time and stop. And then when you do, you're like, oh, I didn't realize how much I really needed this and how much better I feel. So thank you. Next up, we will be exploring the topic of genetics and breast cancer with Jessica Kenny, certified genetic counselor and manager of clinical genetic counseling at Catholic Health Services. Welcome, Jessica.
Thank you so much. Good morning, everybody. My name is Jessica Kenny. I am the manager of genetic counseling at Good Samaritan Hospital, so I work for Catholic Health Services. We are a multi-specialty genetic counseling clinic where we do oncology services, cardiogenetic services, prenatal and preconception, and pediatrics. But I'm here to talk about cancer. I also oversee our services at Mercy and St. Catherine's for oncology services. And oncology is probably the biggest reason why our genetic counseling clinic is in existence. So today we're going to talk about the importance of genetic counseling in the setting of breast cancer. I know that when a female or a male receives a breast cancer diagnosis, it can be extremely overwhelming. Not only did you just hear words that you hoped to never hear, but then you're also being saddled with a litany of other things to do. So sometimes there's additional imaging that needs to be done, additional biopsies that need to be done, additional opinions that you might need, other doctors to see, other healthcare providers, and of course genetic counseling is sometimes one of the list of things that's also added to your list. And it's almost kind of becomes very overwhelming for the individual to hear all of the information that they just heard, in addition to the fact that they just got cancer. And also, hey, can you carve out an hour and a half of your time in the midst of all these other appointments that you've just been told that you need to do to go see a genetic counselor? So today I'm going to talk to you about why we want to do genetics on you and the importance of it. I'm going to answer some of the questions that have already been asked. And I'm also going to skip through some things that some of the other presenters have already gone through. So we're going to talk about the differences between genetic counseling and testing. Counseling is actually the consultation part that you meet with a genetic counselor for, where testing is testing of the actual genes. We're going to talk about guidelines and criteria. We did see some guidelines and criteria so far, but I'm going to expand on them from a genetic perspective. We'll talk about the differences between hereditary cancers and non-hereditary cancers. We're absolutely going to talk about breast cancer genes, not just BRCA. We're going to talk about inheritance patterns on, so for instance, how things get passed on in generations. We're going to talk about family history, and then we're going to talk about recommendations for treatment and or prevention. So genetic counselors are board-certified medical professionals. We get extensive education and training in medical genetics and psychosocial, otherwise known as emotional counseling, because what we're talking about can be very emotional and anxiety-inducing. So we need the tools and the skill set to help the patients navigate their anxieties if they know that they have a hereditary component that contributed to their cancer diagnoses. What we do, as I said before, we ask for you to carve out about an hour to an hour and a half of your time, because we're going to do a deep dive into your medical history. We want to know what's going on with you. We're also going to do a deep dive into your family history. We want to know if there are any other cancers in the family besides breast and ovarian cancer. That's a common question in the setting of breast cancer diagnosis. Do you have any other cancers in the family, specifically breast or ovarian? But we tend to forget to ask about other cancers such as colon, kidney, thyroid, uterine, so on and so forth. So we're the individuals that are going to look at your entire family history from a big picture. We're going to review your psychosocial. We're going to take an emotional gauge, if you will, to see. We do ask, do you have a diagnosis of anxiety or depression? Are you the type of person that is particularly anxious? So that we know if we're going to give you bad news about your test results on the back end, how to handle you with kid gloves, in a sense. We're going to talk about genetics. We're going to tell you what our genes do, what genes we're going to test, what we might find, what types of results we might find, what we might tell you based on certain types of results. And of course, we're going to give you recommendations in the setting of a genetic mutation, or even if you don't have a genetic mutation, we're still going to give you recommendations. We can facilitate the genetic testing process. You do not have to do genetic testing through your doctors. It's actually ideal that you come to a genetic counselor and learn about everything that you might potentially learn about your results as an informed consent process. This is a really important point. There are certain things that you need to know about before you say, go ahead, draw my blood, and send off my sample to be analyzed. We will also interpret the genetic test results. A lot of medical providers, when they're in their training, unless they specifically get a genetic education or seek it out at an extensive level, may not understand what your results mean. So we're going to be the ones to tell you what the results mean. And we're also going to give you education on potential discriminations that you might encounter if you are gene mutation positive. So hereditary cancer genetic testing, we've also heard it be referred to as germline testing. So our genes are present in every single cell of our body, including our reproductive cells. We tend to refer to our reproductive cells as our germ cells. So our germ cells are how genetic mutations get passed on through the generations, and that's why we call this germline. Not to be confused with some of the genomic testing that's already been discussed today, which is what we call somatic testing, where we're looking at spontaneous mutations that could have developed in genes that could contribute to cancer diagnoses, but these are not hereditary or germline. They don't get passed on through the generations. We're testing genes that are already present in the body. I say this specifically because I hear a lot of misconceptions of, oh, I have the BRCA gene and that's why I developed cancer. Guess what, everybody? We all have the BRCA gene. Doesn't matter if you're male or female. We all have the same cancer genes. We all have the same genes in general. So really what an individual should be saying is I have a problem with my BRCA gene, or I have a mutation in my BRCA gene that contributed to my cancer diagnosis. And then, of course, we're going to give you implications for cancer treatment if you have a diagnosis of cancer. If you have not had a diagnosis of cancer, we're going to give you information on how to prevent with screenings and or potential surgeries. So like I said, we're going to talk about standards and guidelines. Some of the standards and guidelines that contribute to whether it's appropriate for an individual to have genetic counseling and testing are the National Comprehensive Cancer Network, USPSTF, I'm going to call out the American Society of Breast Surgeons in a moment. And of course, your insurance has their own criteria and guidelines that either meet NCCN, USPSTF, or ASBRS, and they follow them to the letter, or maybe they put their own restrictions on top of that to decide whether they want to pay for your genetic consultation and or if they want to pay for your genetic testing. So NCCN has been in place for when it's appropriate to do genetic testing for about 20 years now. NCCN and a lot of other guidelines have been a little restrictive over the years, but they've become more loose over the years. So what you're looking at the comparison of the 2019 standards and the 2024 standards. In 2019, we needed to be diagnosed younger than age 45. You can see in 2024, we need to be diagnosed younger than the age of 50. So you can see how these guidelines are becoming a little bit more loose to provide access to genetic counseling and genetic testing for more and more patients. In 2019, and this is really my belief of why the NCCN guidelines have become more loose, because the American Society of Breast Surgeons came in with their own standards and guidelines indicating that any female or any individual in general who's had a breast cancer diagnosis should have access to genetic testing. It doesn't matter when you had your cancer, it doesn't matter how old you were, it doesn't matter if it was 10 years ago, 5 years ago, last year, or if you develop breast cancer at some point in the future. You should have access to genetic testing. The ASBRS guidelines also indicate that you should have updated genetic testing. So there's a situation in which we live where maybe we had testing 5, 10, 15 years ago and we only tested 5 genes. Well, we have a lot more breast cancer genes that we know about now. We're discovering new genes all the time, so new genes get added to these testing panels all the time. So if you only had BRCA, you should absolutely come back and update your testing because there are other breast cancer genes that we want to know about. And a lot of these genes are also associated with other cancer types, which I'm going to show you in a moment. ASBRS also indicated that if you do not have a personal history of breast cancer, but you have a family history or you're high risk, you should have access to genetic testing as well, but you have to meet those NCCN guidelines. And one of my personal favorites is interpretation of results. Sometimes we get an uncertain result. It's called a variant of uncertain significance, which I will explain in a moment. But these are absolutely not actionable. They are not mutations. We do not make recommendations. We absolutely do not do surgeries based off of uncertain findings. They do get reclassified over time. So in terms of cancer genetics, or the differences between hereditary and non-hereditary, we're looking at a pie chart. You can see the very large portion of the pie chart is non-hereditary cancers. So 85 to 90% of cancer diagnoses do not have a genetic mutation that is hereditary that is contributing to that. Most likely it's due to outside factors that we've been exposed to. Only 5 to 10% of cancer diagnoses fall into this hereditary category. When I say hereditary, I'm speaking to the concept that an individual was born with a problem, otherwise known as a mutation in a cancer gene that can predispose them to increased risks of certain cancers over their lifetime. If we find that in an individual who has not developed cancer yet, it's not a slam dunk 100% guarantee that they will develop cancer. They're at increased risks, but we want to know about these things so that we can prevent them. This is kind of like what I explain to patients in terms of non-hereditary causes, outside factors, lifestyle factors. It's all kind of right on the slide. But let's talk about our genes. So our genes are the basic building blocks for humans to grow, develop, and function. So I describe this to my patients as your genes are kind of like a written instruction booklet that's telling your bodies how to grow, develop, and function. We all have about 20,000 genes. As I said before, we all have cancer genes. We all have the same genes. It doesn't matter if we're male or female. We have the same genes. Also, another concept that's extremely important that I'm going to come back to in a moment, we have 2 sets of DNA. we get one set from each parent. So what that means is that we end up with 2 copies of every gene in every single cell of our body because we have a copy from mom and a copy from dad. And I'm gonna illustrate that in a moment to show you how things get passed on. But here's our breast cancer gene slide. So there's a lot of genes listed here. It's not just BRCA. We hear about BRCA all the time because they were the first 2 breast cancer genes that we discovered in the early 90s. They're extremely well researched and studied. We have a lot of very detailed guidelines on when we should test people, and also if we find a mutation, what we should be telling them about treatment and prevention. But you can see ATM, BARD1, BRIP1, CDH1, CHEK2, the line that has MSH1, MSH2, EpCAM, that's considered Lynch syndrome. NF1, PALB2, P10, the RADS, STK11, and TP53. If your genetic test reports don't show all these other genes, you weren't properly tested. Please come back to your doctors or your genetic counselors and have updated testing. In the middle column, you can see the risks. So BRCA is our highest risk breast cancer gene. We're looking at somewhere in the ballpark of 55 to 72% lifetime risk to develop breast cancer, our first breast cancer. Then there's an over 20% risk of developing a second breast cancer if we're BRCA positive. So I keep saying I'm going to talk about treatment and guidelines in a moment, but let's look at ATM and BARD1. ATM, the risks have come down. So those NCCN guidelines that I showed you before, we get updates on those at least once a year, sometimes twice, if we're lucky, 3 times a year. And a lot of what's being updated are the risks for cancers, prevention, management, and when it's appropriate to test individuals for these genes. So ATM used to have a higher risk with less research. With more research, we know that it's a lower risk, more moderate risk gene. We may not recommend prophylactic mastectomy, or we may not go into, if you have a breast cancer diagnosis, you absolutely need to remove both of your breasts. Maybe we will say, it's better if you think about a lumpectomy, but we're gonna wanna follow you a little bit more closely going forward to make sure that you don't develop breast cancer in the opposite breast in the future. But what you're looking at on the screen, the other chart on the other side is an example of a genetic test panel. I use this to illustrate to my patients that even if we're just doing BRCA testing, we wanna know about other cancers in the family because these genes don't only result in breast cancer. I'm gonna use BRCA a lot as my example. BRCA is also associated with increased risk of ovarian cancer, prostate cancer, pancreatic cancer, and melanoma. You need to know about these things because you need to know about how to prevent those other cancers once you get through your breast cancer treatment. So the other chart is the genes are listed in the gene column. If we find a mutation in one of these genes, you're seeing the colored dots in the columns corresponding to the organ in which there might be an increased risk of cancer. So what I said before, we do a family history, we're asking about any type of cancer in a family. And these are what our family trees look like. We do a 3-generation family tree. We start with the person in front of us, and we build up and out, and if they have children, we include their children as well. So we ask about, has anyone had any lumps or bumps, any biopsies, anything precancerous, any atypical cells? Has anyone had any colon polyps? Has any women in the family had a need for hysterectomy or removal of their ovaries? And if so, why? Do you know the reason? Well, my mom maybe had some precancerous cells in her uterus. Well, we want to know those things because we want to know if there's a pattern that looks like this chart where we're seeing multiple different types of cancers and maybe they roll up into a cancer syndrome. We want to be able to appropriately inform you and appropriately evaluate you from an intake perspective to figure out, do we think that these cancer syndromes are going on? It also helps us figure out which genes we should include in your test and make sure that we're not missing any genes. So what you're looking at in these family trees is 2 different BRCA families. They look very different. The one on the left is breast cancer specific. So we would expect to see that, except for the one male at the top who's got the prostate cancer. The one on the right looks very different. It's not just breast cancer. You're seeing breast cancers, you're seeing ovarian cancers, you're seeing prostate cancers, you're even seeing colon cancers and thyroid cancers. And then on the right side of the tree, you're seeing pancreatic cancers. So we absolutely want to know about every cancer type that is in your family. Risk factors for hereditary cancers. We heard about Ashkenazi Jewish, we heard about African American. The reason why every single female gets asked if you have Jewish ancestry at the diagnosis of a breast cancer is because there's a higher carrier rate of BRCA mutations in the Ashkenazi Jewish population than in the non-Ashkenazi Jewish population. It's 1 in every 40 will have a BRCA mutation. Whereas if you're not Ashkenazi Jewish, it's 1 in every 300 to 500 will have a BRCA mutation. So that's why, yes, that's why we ask you if you have Jewish ancestry. I have patients sitting in front of me and they say, why is everyone asking me this question? This is why we're asking the question, because it's contributing to whether we think we should be testing BRCA. Of course, we're going to test BRCA in the setting of breast cancer, but should we be testing other genes as well? We want to know the age at which you developed cancer, the type of cancer, have you had any other cancers, are there family members who've had multiple cancers, different cancers, the ages at which they were diagnosed. At or below the age of 50 is kind of like our cutoff for driving up red flags. So young ages of diagnosis definitely make us think a little bit more about a hereditary cancer syndrome. And of course, we do also want to know if there's a hereditary cancer gene mutation in your family members, because there may be a chance that you're carrying it as well. Dominant inheritance is what contributes to most cancer genes. So what this means is, like I said before, I'm not even going to refer to this chart. I'm just going to use my hands. So watch my hands for a moment. We all have 2 copies of every gene. If one of those copies has a mutation on it, it's not working properly. Each time we have children, we can only pass on the healthy copy or the mutated copy to our kids, because our partner passes on the second copy of all the genes to the kids. So we're either passing healthy copy or a mutated copy. It's a 1 in 2 chance or 50% risk to each of your kids. Now, if you have an equal amount of kids, that does not mean that half will have them, half will not. This is a flip of a coin with each pregnancy. 50% chance to each child. You also, if we find that in you, inherited that from one of your parents. So it's not just affecting you. There's a 50% chance that if you have siblings, that they also might be carrying it. There's a 50% chance that if they're carrying it, that they pass it on to their children as well. So there was a question earlier about when to test nieces if they're only brothers. It's my belief that that person who asked that question should have genetic testing first to see if you have a mutation. If you do not, then your brothers don't need to be tested. If you do, then there's a 50% chance that your brothers need to be tested and a 50% chance that they could have passed it on to their daughters. Sometimes we do live in a recessive inheritance situation. This is very rare for cancer genes. Recessive disorders outside of cancer that I'll talk about, that I'll just mention are things like cystic fibrosis, sickle cell anemia, thalassemias. Basically, both parents need to have a mutation on one of the 2 copies of their gene to be considered carriers. They are not affected with the disorder that that gene is associated with, but because they're a carrier, they have a 50% chance of passing that on to their child. And if they get together with another carrier of a mutation in the same gene, and that parent also passes the mutated copy, there's a 25% chance that a child is affected, has both mutated copies of their gene, and like I said, this is very rare in cancer genetics, but sometimes this comes up because there are some recessive genes that are included in your test, and sometimes the report says carrier at the top, and so you don't need to worry about increased risks of cancer in those cases. But not everyone understands what that word carrier means. Genetic testing, as I said, is germline. We either take a blood sample or a saliva sample. Now, different patients will be like, well, I prefer the blood because I know that's going to be more accurate. Other patients don't really care as much. Our DNA lives in our white blood cells. Our white blood cells are present in our saliva and our blood. We can get an accurate genetic test result from a saliva sample. So if someone's saying to you, we can do saliva, it's going to be as accurate as the blood. We take one sample, we can test many genes. The chart that I was showing you before was 48 genes. We can test up to 91 cancer genes these days. So we can take one sample and test that many genes. Results will take a few weeks to come back. It depends on the urgency. If you're newly diagnosed, we try to get you in as soon as possible, because we can get your test results in about 7 to 14 days, is pushing it a little bit, but at least we can get you an answer, hopefully before you go into surgery. If you are not newly diagnosed and you're coming in because you have a family history of cancer, then results are not going to be that quick. They're going to take about maybe 2 to 3 weeks. Types of results. If we do find a mutation, it's a positive result. And some reports have a big plus sign on the result to indicate that there's a positive finding. If there are no mutations found, it's a negative result. Sometimes we still have lots of cancer in our family, even though we have a negative result. And we have to kind of go back and think about all of the exposures and lifestyle factors that maybe we encountered over time. And then sometimes we have an uncertain result. So I'm going to spend a minute on this. So variants of uncertain significance come up in about 20% of genetic testing. The reason they come up is because a lot of genetic research has predominantly to date still been only done on Caucasian populations. So our reference of what's normal is somewhat limited. There are also very large countries around the world that still have never done genetic testing on any of their citizens. So we're missing all of the normal variations that live in our genes that make us different and not clones of one another. We all have a normal amount of variations. So sometimes a lab will pick up on a change in a gene, and they don't know, is this gene conclusively normal and benign to the individual? Or is this gene something that's suspicious and we should consider a mutation? They are not going to reclassify that until they are 100% sure that they are going to give an accurate classification, but we're very comfortable with these uncertain results in cancer genetics to know, studies have also been done, 90% of the time, variants of uncertain significance are reclassified to benign. And before these studies were done, there were patients out there that had inappropriate surgeries, they had their breasts removed, they had their ovaries removed based off of uncertain findings that then got reclassified to benign. So please do not confuse a variant of uncertain significance with an actual mutation. And then, of course, based on your results, we're going to give you recommendations. So if you already have cancer, if you already have breast cancer, in the setting of a BRCA mutation is really when we're going to hone in on maybe you should consider a bilateral mastectomy because there are such high risks of developing a second breast cancer. With some of those lower or moderate risk genes, we can safely do a lumpectomy, but as I said before, we want to follow you more closely in the future. We want to make sure you're getting breast MRIs every single time that you get a breast screening, staggered with your mammograms and sonograms. So sometimes if we find mutations in lower risk genes, we still want to give you information to prevent, but maybe it's not as serious as something like a BRCA. Also, we heard Dr. Nouri before talk about PARP inhibitors. These were FDA approved for BRCA mutated cancers several years back. More and more are they being used earlier and earlier in the course of treatment, and they may not necessarily need to be a BRCA mutated cancer to be used. We're also using immunotherapies. It depends on what gene we find a mutation in to indicate whether we're going to say, hey, maybe you should have a PARP inhibitor, or maybe you should look at immunotherapies. Also chemotherapy agents. Certain mutations in certain genes, again, going back to BRCA, platinum therapies are better effective in BRCA mutated cancers than non-platinum therapies. So that's what we would give you in terms of information if you are gene mutation positive. Other things that we might talk about. We might talk about if you have not already had cancer, or maybe we need to talk about prevention and detection of other cancers in the future. We do talk about preventative surgeries. If there has not been a breast cancer diagnosis yet and you're BRCA positive and you're young enough, we may recommend prophylactic or preventative bilateral mastectomy because it is a risk reduction of up to 90% to reduce your risk of developing breast cancer. Individuals who are at risk for uterine or ovarian cancer, there are no great screenings for uterine and ovarian cancer. Our pap smears only look at cervical cancer. That's not something that everyone understands. So we want to be able to remove your uterus and your ovaries to reduce your cancer risks in those organs as well. Very rarely are we recommending removal of your colon. There are some cancer syndromes that have 100% risk of colon cancer. So those are the individuals that will say, hey, maybe you want to consider removing your colon to reduce your risks. And very rarely are we talking about removal of the stomach, but there's one gene that was on that chart that is associated with a very progressive form of stomach cancer that's hard to detect. And that's why we would give that recommendation. If we're not talking about surgeries, we're absolutely talking about increased surveillance. We want to make sure you're getting your screenings at appropriate intervals. We want to make sure that you're getting your screenings maybe a little bit more frequent than general population. We want to make sure that you're getting more sensitive screenings. So what I mean by that is, should you be having breast MRI in addition to your mammograms, and they're staggered 6 months apart, so every 6 months you're getting some kind of imaging of your breasts? If we're at risk for colon cancer, maybe we should be having more frequent colonoscopies. So that's what I mean by more frequent screenings. Or should we be imaging other parts of the body that we're not thinking about and we don't have general screenings for? So for instance, maybe we're at risk for kidney cancer and we should be doing CTs or MRIs of our kidneys, or maybe we should be doing MRIs of our pancreases because we have a gene that's associated with a pancreatic cancer or a family history of pancreatic cancer. And then we can also give recommendations for what we call chemoprevention. So this is, we can take tamoxifen before we develop breast cancer if we know that we're high risk for breast cancer. And then in the settings of very high risk cancer syndromes that are associated with colon cancer, individuals can take very high doses of aspirin. Please don't run out and start taking very high doses of aspirin without talking to your doctors first, because there are other things that you need to consider in terms of other medications, but that has been shown in research to be preventative. This is an example. I showed you the NCCN guidelines on when it's appropriate to do genetic testing. This is on the back end. When we find a mutation, what do we tell you? So I kind of gave you little snippets. This is specific to BRCA. If you have not developed breast cancer yet and you know you have a BRCA mutation, we absolutely want you to start breast MRIs by the age of 25. Then you can start your mammograms at 30. But the most sensitive screening is what's being done first. A lot of women will say, I have a BRCA mutation, or I have a mutation in another gene, and I want my daughters tested as soon as possible. We will not test your children before they turn 18. They absolutely need to have their own autonomy. They have to be legal adults. They have to want to know this information for themselves. But we want to test them by the time they turn 25. If we do it earlier than that, you have to know your children. You have to know their mental capacity. Are they anxious? Are they the type of kids that are going to freak out because they know that they have a genetic mutation before they can do anything about it? So people will call us and say, my daughter just turned 18. Can she come in and get tested? Maybe not such a great idea because you can't do anything about it until she turns 25. So absolutely bring your daughters in by the time they turn 25, but maybe let's hold off a little bit. If you know that your children are not very anxious and they can handle information and they can handle the uncertainty of living with this and not being able to do anything about it for a few years, sure, bring them in. But we want them to be legal adults because we don't do this testing in children unless they have cancer diagnoses in a pediatric setting. But we want them to be legal adults. We want them to have their own autonomy. And we also want to make sure that they have life insurance first. So I'm going to talk about that in a moment. For the question, for the individual who asked about men can get mammograms. Men can do their self-breast exams. Men can, if they have a BRCA mutation, they should absolutely consider a mammogram by the age of 50. But if there's a male breast cancer in the family, then men should seek out screening 10 years earlier than the earliest age of a male breast cancer diagnosis or in a first or second degree family member. For BRCA, we're also going to talk to you about removing your ovaries and your fallopian tubes by certain ages. It depends on whether you're BRCA1 positive or BRCA2 positive. Men, we want to make sure that they're getting their prostate screenings a little bit earlier than general population. For BRCA2 individuals, we want to make sure you're seeing the dermatologist every year because you have a risk of melanoma. And then sometimes some of the studies have shown that BRCA mutations might also contribute to uterine cancers. It's not something that we know about very commonly, but that is something else to consider. So some limitations and risks for genetic testing. Sometimes we get a negative result, but our families are riddled with cancer and we don't understand the negative results. So I will tell you, we are still kind of scratching the surface in genetics. I did say we have 20,000 genes. We don't know what every single one of them does yet, so we're still discovering genes all the time. So this could be a situation in which, did you and your family members all experience the same kind of exposures and lifestyle factors? Or is there something hereditary that we just haven't discovered yet to be able to put it on your test to include it in your test? And that's why we say come back and get updated testing at some point in the future. I went through variants of uncertain significance. That is a limitation. I will tell my patients, if we find a VUS, I'm going to show it to you, but I'm not even going to go down the rabbit hole of what types of cancers it's associated with, because then patients start picking, and I have that in my family, and I have that in my family, and that doesn't mean that this is relevant to you. So we got to be careful about those. Insurance discrimination, I have a slide next. Sometimes we have an unclear utility of results. So sometimes we find a mutation in a gene that has no association with breast cancer. Maybe it's associated with kidney cancer. And we're kind of like, what do we do with this now? So we give you the information, but then you're left going through cancer treatment and worrying about other cancers in the future. And so sometimes the result doesn't really make sense. Newer genes that we discover may not have as detailed management guidelines, so we may tell you, hey, we found a mutation in a gene, we know it's associated with increased risk of XYZ cancer, but we can't tell you the percentage at which you're at increased risk for. We can tell you there are elevated risks. And if we don't have enough information, we may not be able to tell you what screenings and management you should be seeking out. So there is a little bit of a lag time, but we do get those NCCN updates periodically. So maybe we can't tell you anything now or next year, but maybe in 2 or 3 years or 5 years, we'll have more information and we can tell you information then. As I said, this is a detailed informed consent process. Insurance coverage ebbs and flows as to whether they cover genetic counseling and genetic testing. Some insurances, doesn't matter, they'll cover genetic testing whether you meet guidelines or not. Some insurances will not. Specific insurances like Cigna and Aetna, they will not approve genetic testing unless you see a genetic counselor first. So if you're the type of person that says, oh, I'll just have my doctor do it, that's fine, but it's probably going to be denied, and you might have to pay a large bill on the back end. The ebbs and flows of insurance coverage really kind of go along with how well the economy is and whether the insurance company wants to pay for it or not. Sometimes they get a little restrictive. I've seen these things change over the years. Sometimes we have really good coverage, sometimes we don't. Insurance companies change their minds all the time. But it's improving. But what's important to know is there is a cash pay price of $250. So if your insurance denies or you have a high deductible that's going to get flagged, you can choose to opt to the cash pay price of $250, and that's the maximum out-of-pocket cost for your genetic testing. And results are permanent, with the exception of variants of uncertain significance. Whatever we learn about your genetics, because we're looking at your genes at a sense of how you were born with them, so this information is always permanent. Whatever results you already have on your genetic testing will always remain the same. The only reasons to do updated genetic testing is because we found more genes to test. And that's the information that, not that it changes, but that would be a reason as to why we want to update. GINA. GINA is a federal law that was placed in 2008 that provides protections for individuals when they test positive for genetic mutations. This provides protections in the setting of discriminations, for medical insurance and employment. So if you test positive for a genetic mutation, your current or future medical insurance cannot discriminate. They can't say it's a pre-existing condition, they can't drop your coverages, and they can't try and get more money out of you by charging a higher premium. This is if you change jobs and you get a new insurance at some point in the future, same applies. When you go on Medicare, same applies. For employment, as long as you do not work for the military, do not work for the government, and you work for an employer that has over 15 employees, you cannot be discriminated in the workplace based off of having a genetic mutation. The exception to this law is life insurance, long-term care, and disability. So this is part of the informed consent process. Not everyone knows about the life insurance piece. So I'm gonna be the person to tell you, do you have enough life insurance? Are you the type of person that thinks that you want to buy more life insurance? If so, go do that first and then come back to me and do testing. I'm not going to do your testing because I'm not going to be the person responsible for putting you in the position of not being able to get life insurance. So life insurance can discriminate. Patients ask me, well, what if I just don't disclose it to them? Okay, that's fraud. But you're also going to sign a medical release that's going to allow that life insurance company to do a deep dive into your medical records, and they're going to find things that you forgot about. So they're still going to find out about it. So if you already have life insurance in place, it doesn't matter what we learn, but if you don't already have life insurance in place and you have not had cancer, you can go get that first and then come and get tested. In the setting of having a cancer diagnosis, that can also contribute to whether life insurance will cover you or not. So a lot of times I see families that will say, I want to bring in my kids. Great. You want to bring in your kids when they're 20 or 30? That's fine. Get them life insurance first. And then this also applies to long-term disability, long-term insurance and disability. These are policies that are outside of our employment. So a lot of people will say to me, well, I have life insurance through my job. That's great. I'm talking about like a Mass Mutual, a Liberty, Metropolitan, those extra policies that you buy outside of employment. I would advise getting a whole life insurance policy, not a term, because the term terminates out, whereas a whole can be somewhat of a forced savings account later on in life. So when should we get genetic testing? We should do it at the time of diagnosis. We can, if we don't want to do it then because we're so overwhelmed with all of the other appointments that we're going through, you could do it any time after treatment, as you're going through treatment. Doesn't matter where you are in your process, you can always come to us. If you were diagnosed 10 years ago, 20 years ago, 30 years ago, and you never had testing, you can still consider it. You can still come in. When to update testing? About every 5 years. Because like I said before, we add new genes periodically, about every 5 years. There is a specific about BRCA, if it was prior to 2013, just because of the type of technology that was being used. There are two types of technologies that are kind of wrapped into one now, whereas only one technology was being used prior to 2013. So there are individuals out there, if they did not have testing of both technologies, there is a situation in which there still might be a BRCA mutation that we could pick up on, even though they were told they were negative. So that's another reason to see a genetic counselor, because we're the ones that know to look for the keywords in your reports to determine, did you have comprehensive testing prior to 2013 with both technologies, or were you missing? When to recontact your genetic counselor. We want to know if you have any new cancer diagnoses. We want to know if your family members have any new cancer diagnoses. We want to know if sometimes patients will call us back and say, I had a variant of uncertain significance, I tested with you in 2020, do you have any updated information about it? That will prompt us to go back and look at, did the lab reclassify the result, or there are public databases that all the labs contribute to, so if that specific lab didn't reclassify the result yet, we can look at this public database to see if other reputable labs reclassified, and we can give the patient information as to whether they should be concerned about their uncertain finding or not. And then every 2 to 3 years to inquire if the previous testing is still relevant. So we get these phone calls all the time. Hi, my sister was just diagnosed with uterine cancer. I saw you in 2017. Do I need updated genetic testing? We look back at their testing, we look back at their genes, and we can tell them either your testing is still relevant, you don't need to come back, or actually more genes have been added for that cancer type, maybe you should come back and get updated testing. And the last slide I want to talk about is breast cancer risk assessment. So this was touched on by Dr. Rappaport in terms of when do we do breast MRIs if we have not had a breast cancer diagnosis yet. We've heard very well this morning that women should start getting risk assessments at the age of 25. But what this is called Tyrer-Cuzick, another name for this is IBIS. There's a breast cancer risk calculation that's popping up on a lot of your mammogram reports if you had not had breast cancer and you do not have a genetic mutation in a breast cancer gene. So I know that we're doing this at Good Sam, we're doing this at Catholic Health, where we take into account your age, your height, your weight, your hormonal history. Did you have children? At what age was the first child born? Are you pre or postmenopausal? Your breast density, your family history, your genetic testing information, and it gives us a risk. If you are 20% or higher, we want to make sure that you're getting breast MRIs in addition to your mammograms. Again, with that staggered approach, because since we implemented this program at our centers, we have found individuals that are at that 6-month mark between their mammogram and they're about to get their MRI, and they've been picked up with a very early stage 0 cancer. We also heard about a very notable actress in the last few months who had this situation. She was considered high risk, she had an MRI, and she was picked up for a very early stage breast cancer, and she was very thankful that she was getting these MRIs. So if you start seeing breast cancer risk calculations popping up in your mammogram reports, remember, these risks are not applicable to you if you've already had breast cancer, or if you have a gene mutation because you're at the risks of the gene mutation. But this is being done more and more settings. Of course, if you see a breast surgeon, they will do this on you as well. Gynecologists can do this, genetic counselors can do this, and mammography imaging centers are doing this. So that's all of my slides. I'm happy to take questions.
We can take a quick 1 to 2 questions. We'll start over here.
Hi, can you just repeat what your recommendation was for someone who's had breast cancer but not BRCA positive, how that is involved, say, with a brother or nieces or their own children, for someone who wasn't BRCA positive? What's the hereditary issue? You mentioned it, but I think I'd like to hear it again.
So if you were tested comprehensively, meaning we did all breast cancer genes and not just BRCA, and we know that nothing else is occurring, then you know that you didn't pass anything on to your children. Sometimes we live in a situation where breast cancers are so common that there could be a hereditary cancer syndrome in the family, so there might be other cancers in the family, but the breast cancer is kind of like incidental, and it's not, we can't find the mutation in that individual, but we still recommend that your family members come in based off of the other cancers in the family.
So the question before was about a brother and the brother's children.
Right, but that individual did not have genetic testing. So that's why I said it's advisable that she has genetic testing first before her brothers come in. If she doesn't want genetic testing, that's fine. Her brothers can come in.
So I've had the genetic testing and I have a niece. Do we have to worry about her?
Well, you can't just think about your side of the family. You have to think about her other parents' side of the family as well.
Gotcha.
Yeah.
Okay. All right. Thank you.
Hi. Thank you for your talk. I have a couple of questions. One would be about the BRCA gene. And I know you said if there's risk that they should have it done earlier, they should use things like the Gale model or ways to figure out if they are at high risk. My concern is that, because I have a personal situation with my daughter-in-law who found out that she had breast cancer while pregnant and now carries the BRCA gene. And my son and daughter-in-law are both really, really upset because during the pregnancy, they got tested for every rare genetic disease for the baby.
It's not the same testing.
Exactly, and nobody ever said anything about getting the BRCA gene. And the thing, what I want to say is that besides her GYN or internist, never offered that to her. She never had family history, and she got the BRCA gene from her father. And I think we need to make sure that young men and women from their, it needs to be told to the internists, because men typically have a PCP or women start going to GYN, that they need to ask about their, not just family history, but their cultural heritage. If they're an Ashkenazi Jew,
Exactly,
then they
yeah.
absolutely should be getting a BRCA gene tested before we deal with the situation that they're dealing with now.
I 100% agree, and that's also a misconception. We tend to only think about our female side of the family, and think that that's the only chance that when a mutation can get passed on, but it's a 50% pass-on rate whether you're male or female. So yes, that individual or your daughter-in-law should definitely have been recommended to have BRCA testing in the setting of really just being diagnosed with breast cancer. What she had done in pregnancy is called carrier screening. So we will do carrier screening to see if individuals have recessive disorders, but that does not include cancer genes, and it absolutely doesn't include BRCA. So that's a common question. People will say, well, I did all this genetic testing when I was pregnant. It's not the same. Yeah.
And then just my other question is, for someone who does have BRCA1, and we know about the risk for breast, and we also know about the risk for ovarian, at what age do you typically recommend a prophylactic total hysterectomy for someone who has the BRCA1 gene?
So BRCA1 recommended for what's called hysterectomy with bilateral salpingo-oophorectomy. So the bilateral salpingo-oophorectomy, are the fancy words we use to say we're going to remove your ovaries and fallopian tubes, is recommended between the ages of 35 and 40. That will put someone into surgical menopause, so that's also something to consider. Okay.
Thank you so much. This is actually for you. Thank you so much, Jessica. Okay, Kristin Thorne had to step out, so I just want to introduce myself. My name is Janine DeGennaro. I am the Director of Marketing and Communications for New York Plastic Surgical Group. You usually see me on the sidelines. I'm just stepping in. So thank you, Jessica. That was great. I think that there was useful information for everybody here in this room. It was awesome. So we all know the benefits of staying active and exercising regularly. So here today with us, we actually have Natalie Penny. She's a certified cancer exercise specialist with the Nancy Marks Cancer Wellness Center at the Sid Jacobson CCC. She's going to take us through why exercise is especially important for women dealing with the breast cancer diagnosis. Natalie?
Yeah. Maybe tap your feet on the floor. Feel your feet move, head to toe. And then if you want to, stand up and sit down a couple of times. But don't leave the room. So yes, I'm Natalie Penny. I'm with the Nancy Marks Cancer Wellness Center at the Sid Jacobson JCC. And I'd just like to read out what our mission is at the center. We're dedicated to supporting those affected by cancer, providing free, individualized services that nurture the mind, body, and spirit. We believe that everyone affected by cancer deserves access to a community and resources that will help them and their support systems cope with the challenges of cancer. At the center, we offer exercise classes such as strength training, yoga, a walking group, among other things, educational programming, professionally led lectures, forums, and creative arts workshops, counseling and referral services, individual counseling, care management, and a resource network such as what we have here, discussion groups tailored to various demographics, including care partners. And our annual events, there's an off-site retreat offered, and our annual 5K, which is a fundraiser for the programs. You can also look at the website and look up more specific dates and times of these events. So the benefits of exercise for breast cancer survivors are to alleviate symptoms of treatment. We want to get active if you're not already, and stay active as much as you can. So alleviating side effects of cancer treatment improves overall quality of life, which is essential to your healthy lifestyle. Doctors recommend it. They recommend you stay active or avoid inactivity. This combats fatigue, and the studies prove that exercise is the most effective defense against cancer-related fatigue and stress-related symptoms. Now, breast cancer survivors face additional challenges when it comes to finding motivation to exercise. But all of this stress, you've just found out you have a cancer diagnosis, you want to sit down with yourself, last thing you want to do is move your body, but moving your body couldn't be better. So the National Institute of Health, National Cancer Institute, shows evidence linking physical activity with longer survival in women diagnosed with high-risk breast cancer. Those who engaged in regular physical activity, meeting federal physical guidelines, which we'll cover in a moment, before their cancer diagnosis and after treatment were less likely to have their cancer come back or to die compared with those who were inactive. So why is this? It improves your cardiovascular and your cardiorespiratory systems, which helps deliver oxygen consumption, nutrient delivery, and waste removal. It hormone regulation, reducing levels of circulating estrogen and progesterone, reduces toxin by secreting waste through perspiration, and it reduces stress, helping you feel good by promoting endorphin release naturally into your system. So here are the guidelines. So the National Institute of Health Cancer Institute guidelines are weekly activity is to be between 2.5 to 5 hours of moderate exercise, or 1.25 to 2.5 hours of vigorous aerobic activity. So aerobic means with oxygen. So you want oxygenated blood moving about your body, helping your organs and systems work as efficiently as they can. So the daily activity, it seems scary to say, oh my God, I got to do 5 hours of exercise every week. It's only 30 minutes a day for 5 days of the week, so you get 2 days off. That's for the minimum. So if you're nervous, you start at the minimum, and if you're really nervous, you try to get to the minimum, so you can be just under. In addition to the exercise, you want to try to, as much as possible, manage your weight. The goal is to be as lean as you possibly can without becoming underweight. So you can get crazy and lose too much weight. That's not the goal. So here are the 10 benefits of exercise. The first one is it promotes well-being and combats fatigue. The physiological benefits, which could be you look better, you're more toned, you're getting stronger, which gives you an increased sense of control of your body. It's going to improve your range of motion, so if you can only lift your arms out this far, you're going to start to be able to lift them up this high. And I just had shoulder surgery 6 months ago, and I couldn't lift my arm at all, and I now can. So... So thanks to the great physicians that we have in our area, as well as physical therapists who can help you, many groups out there that can assist you on your way to recovery. So the exercise also combats weight gain, resulting from treatments, hormone therapies, and stress, eases joint pain associated with hormone therapies, improves your sleep, improves metabolism and your digestive regularity, and increases longevity, improving your quality of life. But it also, very importantly, can prevent and manage lymphedema. So lymphedema is where your lymph nodes start to swell and become inflamed. The size of the limb becomes larger. It can harden. You want to keep that moving by lifting, moving, massaging, drinking water. So exercise makes you thirsty. So you want to really drink before you're thirsty, but if you're not going to, exercise will help you drink a little more water than we otherwise would. So now we go to the mind-body connection. You have to decide to exercise. Your mind has to say it's going to do it. Your mind is going to tell you it doesn't want to do it. It doesn't want to start. But you have to kind of break through that barrier and say, well, I'm going to see how I feel. I'll start with 10 minutes. If I feel not good after 10 minutes, I can finish. If I feel good after 10 minutes, I'll do another 10 minutes. And if I feel much, much better, which you should, because you'll be warmed up 20 minutes in, you can do that extra 10 minutes to get your 30. And then you're good for the day. Okay. So the physiological benefits are improving your cardiovascular capacity. So that's the heart pumping, the delivery of oxygen about your body, decreases your blood pressure, decreases your blood sugar levels, and decreases your cholesterol levels. All of those things also help with weight management. And it can either be a benefit by preventing or reversing any problem in those areas. So breast cancer patients may experience a lack of physical control of their bodies due to living with the side effects of the surgeries and treatments. But healthy lifestyle choices, including exercise, when combined with healthy eating habits, can provide a sense of control that's lacking. We actually have a nutrition class starting next week on October 23rd, 11 a.m. to 12 p.m. at the Sid Jacobson JCC, so we would invite you to attend if possible. Then you could stay on, half hour later, an exercise class starts. That would be with me. Okay. So increasing your range of motion, flexibility, endurance, and strength. Treatment including surgeries, chemotherapy, radiation, immunotherapy, they all negatively impact these. So specific forms of exercise can decrease the effects of treatment. And it's important for people to pick things that they may enjoy, right? So if you're not going to enjoy it, you're not going to do it. But it's also important to have an open mind. So you want to be open to trying new things and being okay that you don't know how to do it right away. It's like, oh, I don't know how to do that. I don't think I belong there. I shouldn't go. I'm not going to go. That's the mindset. You say, I'm going to go, and I'm going to do what I can, and I'm going to see. And each time you go, you learn more. All of a sudden, you're that person that's the leader in the group. And you see the people coming in behind you, and they're feeling all of those same things that you felt. Oh, it's not me. I don't know. Oh, my gosh. And then you can provide inspiration to those people to follow and join in, and everybody then improves together. So yin yoga is a form of a range of motion, flexibility exercise, which uses breath for relaxation. So that's something that most of us could do. Just make sure that you use your own expression of a position that you'd be holding with breath. Then Pilates is another example of exercise you could do for your range of motion, your flexibility, core, using breath for energy, so it's more exhilarating. Cardio, so cardio exercise for people in recovery would be in a zone 1. If there's 5 zones of training or exercising, the first zone is where you want to be for recovery. So if you imagine that you're doing zone 0 by sitting down, zone 1 would be stand up. And then you'd move about a bit. And you do that for the time. So 30 minutes is what your goal is working towards each day. Obviously, when you're starting a new program, you want to make sure that it's clear with your physician or your surgeon. And then you progress on after you've done a number of weeks in zone 1 to zone 2, which would be base training, improving your maximal aerobic capacity. So you're increasing your ability to use oxygen in your body. Resistance training for muscular strength. So this is important when you're trying to get stronger, and if you do have a weight issue that you're trying to reduce, as you lose weight, you need to increase the resistance that you use. So Most times people who have a weight issue will start working out with just their body weight. It's heavy enough, that's enough, you start moving. Once the weight decreases, well, you'll get weaker if you stay with just your body weight. So you have to then start picking up some weight if you want to get stronger. And then moving into the mind itself, meditation, visualization to promote self-healing and a sense of well-being. So you would like to see yourself getting better in your mind, thinking yourself better, thinking positive thoughts as much as possible, but noticing when the negative mind creeps up, because it will. So if, for example, you were running in a marathon and you had 3 to 4 hours out there on the road, not every conversation you have with yourself is going to be a good one. So you accept the negative chat, and then you allow it to pass and move on, because that is what happens. It doesn't stay, it changes, it's constantly moving, and hopefully more positive thoughts can then, diffuse the negative ones. So we've talked about weight gain. Any amount of exercise is better than none, but you want to move away from thinking that way for a long period of weeks. So if somebody says, well, if I do 2 minutes a day, I'm good. So you could do your 2 minutes a day. I know people that do, and they swear by it. I would do my 2 minutes. I'm going to do my 2 minutes. It's over. But, if you really do want to feel better, you have to go past the any amount and get to the 30 minutes a day as soon as you can. So another benefit is to ease joint pain and neuropathy. So breast cancer patients have reported restricted mobility, pain, lymphedema, and impaired sensation and strength after breast reconstruction surgery. Many studies have demonstrated the benefits of early exercise intervention within the first 2 weeks for functional recovery after breast surgery. There's an article cited at the back in the references specific to that. Research shows exercise can help reduce pain and improve daily functional movement. Strength training, flexibility, range of motion, and aerobic exercise improves your joint mechanics by supporting your skeleton, which may then lead to pain-free movements. And the idea is to improve your range of pain-free movement. So you start in the range where there's no pain, and it might be like moving this much. So after shoulder surgery, it was turn your head, and you stay there for 30 seconds. You really stay there for 30 seconds, and you turn the other way. You really stay there. You do the time 3 times through. And that's an exercise. It's a functional exercise, turning your head. And I would imagine it would be the same for any breast-related surgery also. It's close by. Increasing longevity improves quality of life health span. So this is something that, I don't know if you've heard the book Outlive by Peter Attia. This is his book. He talks extensively on improving your life health span. So rather than treating illness to make yourself live a long time, you're looking to live well a long time. So studies through the American Cancer Institute found that physical activity is associated with increased life expectancy by improving your cardiovascular fitness, lowering your weight, lowering your blood pressure. Research also shows that regular exercise boosts the life expectancy of not only healthy people, but extends the life and improved health span of cancer survivors. So physical activity after a breast cancer diagnosis has been shown to improve patient survival rates, including some evidence of decreased risk of recurrence. Keeping active also helps patients cope both during and after treatment by improving general health and well-being. So serotonin is a naturally occurring chemical that is produced as a result of exercising. Hormone therapies, pain and stress may interrupt your normal sleep patterns, so exercising can really help you with that. Those who exercise report improved sleep and less disturbance through the night. And numerous studies show that those who exercised experienced less daytime fatigue-related complaints as well. Not sure the dog will help you sleep, though. Yeah. So exercise also helps you improve your metabolism and your digestive regularity. Exercise to build muscle will lead to better ratio of lean body mass to fat, better proportion of lean body mass. Muscle burns more calories than fat, and decreases the time it takes for food to move through your digestive system. Aerobic exercise accelerates breathing and heart rate, which stimulates the natural contractions of your intestine. And again, drinking water will also promote regularity for your digestive system. So post-surgical recovery and training, you begin gentle prescribed range of motion movements, usually given to you by your surgeon, as soon as it's recommended by your surgeon. Joining a support program with at least one or in combination with an occupational therapist, a physical therapist, or a certified cancer exercise specialist. You begin by starting to slowly walk at an easy recovery aerobic zone 1. Aerobic zone 1 would be a rate of perceived exertion where you're able to talk easily, but you could choose not to. So once you start talking, because it's very easy, actually your level of effort increases. So you want to keep the effort down because you're doing two things. So you want to just focus on doing your one thing as much as you possibly can. Then you'd be able to get to your 20, 30 minutes much quicker. Post-surgical follow-up, get your clearance to begin the next steps in your exercise routine. Receive clearance to increase aerobic volume from 30 minutes to 60 minutes if you can. And then you would increase your level of effort to zone 2 training as soon as usually 4 to 6 weeks if you've been successful in the zone 1. So we talked about 5 training zones in a training program. So training programs using zone 1 and 2 help to bring out the inner athlete in everyone. We all have it. You might think, oh, no, I'm not an athlete. I've never been athletic in my life. But if you move, you can be one, and you are one. So that includes anyone with a cancer diagnosis, either following or post-treatment and recovery. Beginner training programs are usually 4 weeks, progressing to 8 or 12 weeks. So it's nice to have short-term plans, short-term goals, and then the idea, your mind looking further into the positive. I can do this, I can go further into something beyond where I am exactly now. You build a base of recovery in the zone 1, where you can talk, hold the conversation. Then you build endurance at the base level in zone 2. This is also a place where you can talk, but you'd rather not. So your level of perceived exertion would go from 1 and 2 on a scale of 1 to 10 into 2 to 4 on the scale of 1 to 10. So examples of activities for aerobics could be walking, stationary cycling. And I would suggest if you've never been cycling that stationary is where you would start. Not going straight out onto the road with traffic and, all kinds of things that can give you a different reason for a surgery. Swimming, once all your sutures from whichever, body parts have been surgically operated on, swimming is excellent. I used it for myself. You can use it for passive range of motion. The water moves you. As long as you're standing in chest-deep water, you can dunk yourself down. Your arms rise up on their own. It's really very good. It's also very calming on the joints. You can do a lot more activities in the water as it's supporting you. You can't fall down as much. Very nice. So water aerobics is also something we offer at the Sid Jacobson JCC. So here's an example of a training program in recovery. You can see on the left column has week 1, 2, 3, 4. And the total number of hours. So if the minimum requirement was 2.5 hours per week, Week 1 has 3. You're giving yourself a little extra, but it also gives you room to knock something off. So life is happening, life is getting in the way. Oh, look, I can't do all those things. What can I get rid of? And you pick which thing according to how you feel and who you are. You remove one of those things from the week. And if you set yourself a calendar where you can have yourself a program that you feel like you can try to stick to, you don't usually do 100% of it, but if you did 80% of it, that's doing it. So ROM, just to say what that is, that's your range of motion. So you could go back to the slide where it had suggested activities. You could look at yin yoga for a range of motion. Walking, zone 1, everything is zone 1, week 1 to 4. Visualization, meditation. This is just, it's not rigid, it's not fixed. You can change it. So we've been successful in the first 1 to 4 weeks of your training. We're calling it training because remember, in these training zones, you are an athlete. So it's training, you're getting ready, you're getting stronger, you're becoming exactly who you need to be and who you want to be. So weeks 5 to 12, you can see the hours, the weekly hours. We've increased, we've gone above the 5 hours now. We can also see that by 5 minutes, the first 3 weeks, we add 5 minutes each week. So you're not staying static, you're periodizing your training, you're doing a little more. 5 minutes makes a big difference. And again, this isn't a fixed, rigid plan. This is just an example of what your week could look like. Mm-hmm. If other appointments are going to get in the way, life is going to get in the way, you can knock something off because you're already above the weekly suggested time that you should spend exercising. So here we are. We have the reference resources. Randy Height is our director, a licensed social worker at the Sid Jacobson JCC. Her phone number is listed there. Also, the website was on the first slide.
All right, so this is the moment everybody's waiting for. It's a great honor to have with us today Stacey Sager, Emmy-winning reporter and 3-time cancer survivor, as our keynote. Stacey joined the Channel 7 Eyewitness News team in 1996. Since then, she's covered a wide range of local, national, and international stories, including the Bush-Gore presidential election, the war in Kosovo, the Al-Qaeda prisoners in Cuba, the execution of Timothy McVeigh, the death of JFK Jr., the crash of TWA Flight 800, and the horrific attacks of September 11th and the pandemic. I vividly remember seeing Stacey on the news as the towers fell, like running for cover. Following the September 11th attack, Stacey quickly discovered how difficult and personal her job is as a journalist after spending hours with family desperately searching for their loved ones. The sorrow of that week was something she never thought she would see again as a journalist or a human being. But years later, she would discover the pain of the pandemic, telling more of these critical stories. Throughout her career, Stacey has received numerous Emmy Award nominations and has won 7 Emmys to date. In the spring of 1999, Stacey completed a groundbreaking Eyewitness News special on how she was diagnosed with breast cancer at the young age of 30. It was a unique first-person account of the tough decision-making process faced by a young woman in crisis, a story done long before many others would speak publicly about their cancer diagnosis. Then again, in the spring of 2011, Stacey faced yet another cancer diagnosis. Doctors discovered a pre-invasive ovarian cancer in the lining of her fallopian tubes. She was also diagnosed with BRCA1. Stacey decided once again to take viewers along on her journey and the decisions that followed, urging women at risk to get screened for genetic mutations that cause these cancers. Fully recovered, Stacey made it a mission to inspire women to get out and get screened. Then, last year in 2023, Stacey faced her third and most serious cancer diagnosis, another case of breast cancer, but this was in the residual tissue that was left behind in her bilateral mastectomy 25 years prior. While undergoing chemo, Stacey completed a moving documentary. We did send it out to everybody. I don't know if everybody had a chance to watch it. We're going to play a clip of it. It was done on ABC7's New York, ABC7 New York, 3 Decades, 3 Cancers, where she shared her decade-long journey with viewers once again to explain the importance of understanding lifetime risk. Stacey's been honored with numerous humanitarian awards and was cited for her volunteer work with the American Cancer Society. In fact, she's an avid promoter and participant in the American Cancer Society's annual Making Strides Cancer Walk, which raises millions of dollars for breast cancer awareness and research. We actually have the American Cancer Society here with us today. And Stacey will be there, I believe, at Jones Beach this Saturday. So please join me in welcoming our keynote speaker, Stacey Sager, to the stage.
Hey everybody, it's me. I wanted to just speak to you for a few minutes because if you don't see me out there reporting in the flood, there's a reason. We're starting Taxol today. I'm stomping it out. I have another case of breast cancer I'm dealing with. So, it is not the cancer I had 25 years ago. It is a new invasive cancer in what little breast tissue I had left.
My story started a quarter of a century ago. Young women at high risk for breast cancer need to know they should get a mammogram. If I hadn't, well, I don't even like to think about what would have happened. So I had a bilateral mastectomy because of a stage 0 breast cancer and a very strong family history. And I had immediate reconstruction. I looked great, picture of health after that. And lightning struck again. They found an early stage ovarian cancer. It was in both of my tubes. They went back in, they did a staging operation, they took out some lymph nodes in my groin, I had a full hysterectomy. Everything was negative. My ovaries clean, my uterus, everything came out.
It hurts, but it's not so bad.
Here we are 12 years later, the ovarian cancer never came back. Never came back. But then in July, I would feel discomfort when I was sleeping on my right side. And I called my internist and I said, this pain is just really bad. What should I do? She said, Stacey, go get a sonogram, like now. They spotted the mass in about 5 minutes. So there I was on September 11th, lying on a table, hysterically crying. I couldn't believe it. Couldn't believe it. By myself, hysterically crying. I did everything I was supposed to do. And this still happened. And I don't want to scare people, but I want to make them aware that it can happen and you need to listen to your body.
That's 3 Decades, 3 Cancers. It's not a comedy. We just watched an excerpt from it, but I do recommend the documentary highly, and you can still find it on our website, ABC7NY, and a huge thanks to all my colleagues at Channel 7, Portia Grant, who's here today, a huge thanks, especially producer Emily Hartman, who helped so much with that, and photographer Joe Tesoro. Wave to everybody, Joe. He's my partner in crime. Because they helped me make such a deeply personal project a reality. It also has a lot of medical components from my doctors, so I highly recommend it to everyone here from the medical community as well, trying to help your patients navigate this thing that we call lifetime risk. I guess you can say I'm an expert on it. Didn't ask to be. But the documentary comes in very handy whenever I'm meeting with a new doctor, and there have been many doctors at this point, and then they try to catch up on my very lengthy health history. Survivors, you all know what I'm talking about. And it's gotten to a point where I've seen so many doctors, and I stare at them just perusing my voluminous MyChart data. So it's kind of fun to say, just watch the movie. There's a movie already about it. I also would like to thank the New York Plastic Surgical Group for inviting me to be here today. You may not know this, but just 5 years ago, I filled in emceeing this event, and Joan London was the keynote speaker that year. And it made such an impact on me that recently I went back and I interviewed Joan on the very topic that she spoke about here at this summit, dense breasts. And we aired a story for Breast Cancer Awareness Month about what women need to know about dense breasts. And that is the power of this summit. That is the power of Breast Cancer Awareness Month, striking up conversations that lead to more conversations. Because if we talk about this enough, more and more women will hear it. And you'll tell your mothers to get screened, or maybe you'll tell your daughters to get screened, or your sisters to get screened, or maybe they'll see it on social media or on television, or maybe they'll even just hear it on TV. And maybe it will save lives. I know this is possible because I've had women come up to me still about the story that I did on my very first case of breast cancer 25 years ago. 25 years ago. People still come up to me, and women still tell me, because in that story I said a mammogram saved my life. And they come up to me and they say they saw that story 25 years ago and they got a mammogram and it saved their life, and they're still around. So as a reporter, there's really no better reward than knowing that the stories we do make a difference. And if stories can actually save lives, that's like the icing on the cake for a reporter, really. That's the greatest gift of all. After I did my second story on my second cancer, that was the early stage ovarian cancer, I realized the power of this as well. The point of that story was I waited 13 years to get the genetic test after my very first stage 0 breast cancer diagnosis. And I waited, I figured, I had the bilateral mastectomy already. I was just trying to have my kids. What was the rush? So I had my second daughter, and then in 2011, I decided I got the genetic test. I knew it would be positive for either BRCA1 or BRCA2. I didn't know which one. So when it came back positive for BRCA1, I knew I was about the same age as my mom was when she died from breast cancer. I was 44. And I decided to preventively get my ovaries and my tubes removed. And shockingly, I was in that small percentage of BRCA women, patients that already had a cancer brewing. So in my case, doctors came across this cancer. It's called STIC, S-TIC, serous tubal intraepithelial carcinoma. It's an ovarian cancer. It tends to start in BRCA women in the fallopian tubes. And this was all over both my tubes. But I was very lucky because my ovaries were still clean. So it was like a nick of time thing. They caught it. Doctors went back and forth and back again over whether to start chemo on me in 2011 for this cancer. There was really no playbook for this. And after multiple opinions and pathologists at the Dana-Farber Institute weighing in, it was determined that the best guess, and believe me, it was a guess, that the cancer had simultaneously sprouted up in both of my tubes. They said it likely hadn't spread from one tube to another. They suspected because everything else was clean. And so a very wise doctor said, don't do chemo. Save that bullet. Basically a leap of faith. So 13 years have passed, and that cancer never came back. But boy, did I need to save that bullet. Those words echoing in my brain, you don't know how many times. I also want to say that I got an interesting phone call after that story ran on Channel 7. It was from a woman named Cara Diaguardi. I'm not sure if you've heard of her, but she's a songwriter. And at the time, she was a judge on American Idol. And Cara said to me that she was staying at her aunt's apartment in New York City because she happened to be performing on Broadway in the show Chicago. And her aunt had her television on and in the other room. And Cara just happened to hear the TV blaring from the other room. And she heard me talking about how genetic testing saved my life. And Cara told me that that story helped save hers. She got tested, and she tested positive for BRCA2. And that changed her life, really, because she'd been having trouble having a baby and getting pregnant. And anyway, after that surgery, she ended up having a hysterectomy, and then she had her amazing son through a surrogate, and she's not sure all of that would have ever happened in that particular order if fate hadn't put her in earshot of my story. I guess my point is we need to keep talking, people, and listening to each other. Fast forward to last year. What can I say? I thought I was good to go. Prevented cancer number 1 with a bilateral mastectomy, prevented cancer number 2 with a hysterectomy and a staging operation, and I had a lot of parts removed. But what I didn't realize is when you carry a lifetime risk and you prevent these cancers early on, there are just many more years for these cancers to look for us. And I'm not saying this to be bleak, so let me be very clear. I'm saying this to be vigilant. There are no mammograms for women like me who had bilateral mastectomies. My implants are so old, they're saline, they're not silicone, so there were no MRIs to monitor the silicone. And ultrasound annually, well, it's not part of the protocol. Maybe it should be, but it's not paid for by insurance. I was told by my initial breast surgeon back in 1998, the odds are 99% you'll never face breast cancer again. So who knew I would become the worst kind of 1%er? I'm at the front end of a new generation of women, not my mother's generation. We had these preventive surgeries when we were in our 30s and our 40s. And now women are having these surgeries even younger than that, right? And we need to find a way, really, to navigate the decades of our lives. Because the good news is we're living longer. We're living longer. But, cancer can be like a bad boyfriend. You want to break up with cancer, right? And you want to say, see ya, this is really not healthy for me mentally or physically right now. But, this lifetime risk thing, it invades your thoughts. It can make you fearful if you let it. It can keep you up at night, and it can leave you feeling that you need to find future cancers before they find you. I will share with you the ways I've tried to turn this fear around and the lessons I've learned, particularly this past year. And I have 7 tips, actually, coincidentally, for Channel 7. So, number 1, always pay attention to pain. A year ago, I was having pain. I was having pain when I slept on my right side every night, pain in the side of my breast, in the axilla area. That's the same exact spot where that stage 0 cancer was in my left breast a quarter of a century ago. I thought it was my implants. Again, I was programmed to think you're 99% good to go, you just got to get the implants changed out. So I kind of let the pain go for too long, for months, really. And in July of 2023, I called up my old breast surgeon from 1998, and there was a wait to get an appointment with her from July until September 26th. So I made that appointment, but the pain was getting worse. And I couldn't get anyone at that institution to take notice with the urgency that I needed. They were treating me as a new patient, even though I have a BRCA1 mutation, and they had cured me of 2 other cancers more than a decade prior. So finally, at the urging of my internist, Dr. Alice Furman, who's helped me save my life 3 times now, I went for an ultrasound. And I went to Dr. Susan Drosman in New York City, and she spotted the mass on the side of my breast in 5 minutes. 5 minutes. And I was traumatized, as you saw from the documentary. What followed was a very stressful couple of days because the exact pathology needed to be firmed up. The cancer was invasive ductal carcinoma, but it had something called metaplastic features, which means it was almost unrecognizable as breast tissue, so they actually needed to make sure that it wasn't the ovarian cancer that had somehow metastasized all over my body. It was a rough couple of days. Thank goodness, and I can't believe I say this, but thank goodness it was triple negative ductal carcinoma, okay? It's not a great cancer. None of them are, but it was better than the alternative. So So then I decided, yeah, I'm going to assemble a new team of doctors at a new institution and fast. I ended up at Mount Sinai's Dubin Breast Center. This brings me to tip number 2. Don't feel bad stating the obvious to your surgeon. Like, please get every bit of breast tissue out of me when you do this surgery. I'm not angry at my first surgeon. She's a great doctor, and my bilateral mastectomy bought me 25 years, okay? But there was tissue left behind in my axilla area, enough tissue for a 1.8 centimeter mass of triple negative. And so I say to younger women having preventive mastectomies, don't be afraid to state the obvious, get it all out. I also advise women to look for doctors whose patients are still around. Like, that speaks volumes to me. And I don't know how many plastic surgeons we have in this room right now, but please understand something here. Women with lifetime risk, we're not going in for a boob job. So keep your eyes open and be vigilant. We want the best possible outcome cosmetically, of course, but we are going in to save our lives. Number 3, find the gratitude along the way, wherever you can. It will often be the strength you need in your lowest moments. For example, I made posters for each chemo session, posters about my garden, about my daughter's dancing, about my work and my family. I brought the posters to my chemo so I could visually feel the gratitude as the red devil went into my body, or the Taxol, or the steroids. The drugs were my frenemies. I knew I needed them to get rid of the cancer, but I also needed strength to cope with those drugs. Doctors didn't even stage my cancer because it was so rare to have formed in a tiny amount of leftover breast tissue. On paper, it would be a stage 1. My scans were clean. The 6 lymph nodes they removed were negative. But that's often the case with triple negative. And then it can go on to spread to other parts of the body aggressively. And so my chemo was followed up aggressively by 20 rounds of radiation. And now a relatively new drug that I'm on called a PARP inhibitor. This drug, I don't know how many of you have heard of it, the brand name is called Lynparza. Certainly no fun, but I'm on it for a year. It lowers my blood counts, makes me a little tired and occasionally a bit nauseous, but I'm counting months and I go about my days with gratitude. For example, if I'm having a bad day, I close my eyes and I think, where was I last year at this time? And undoubtedly, I'm better. Now, I'm better. This brings me to tip number 4. Every time I feel cursed by my lifetime risk, I actually turn it around and I say, you know what, I'm lucky. I'm lucky because genetic mutations put us in a category of cancers that the doctors understand. I never question why or why me. I know why. What I tell myself is, I'm in a group that doctors have data on. The PARP inhibitors, they were created for BRCA patients like me. The doctors generally look at us that much more carefully, and being high risk, we look at ourselves more carefully, with more vigilance. I remember years ago, I attended a speech made by Dr. Mary Claire King. She discovered the BRCA1 mutation. I was a bit starstruck watching her speak. I mean, she discovered the mutation that, I discovered I had and saved my own life. And I remember specifically what she said. She said she had never met a BRCA patient who wasn't somehow extraordinary. I believe this. We are. Young women who test positive are lucky to get information ahead of time, information that we can act on. My current breast surgeon, part of my new team at Mount Sinai, said to me the other day, Stacey, in 2024, no woman should learn that she is BRCA positive through a cancer diagnosis. That's how far we've come. We now know through risk assessment that genetic testing early on is a must for some people. No woman should have to learn her BRCA status through a cancer diagnosis. We've come a long way. And women who test positive, guess what? We take charge. Let's face it. Fear is a motivator. Women get surgeries. Women are freezing eggs. They're doing this sort of life planning they never thought they'd have to do. And we develop extraordinary coping skills and, in many cases, extraordinary strength. We are lucky and we are extraordinary. We are not cursed. Tip number 5, cancer won't define you, it will refine you. A lifetime of risk and surgeries will refine you. Treatment will refine you, and especially hair loss. Nothing spells fear like suddenly hearing that you're going to be bald. A woman on TV is going to be bald. It terrified me, especially after my first diagnosis, I was fearing I would need chemo, and then after my second diagnosis, I was fearing I would need chemo. But you know, 30-year-old Stacey was not 44-year-old Stacey, and those two versions of me are definitely not the upgraded model, the 56-year-old version. I didn't want to go through cold capping. I called up Joan London again and asked for advice. She told me the best thing. She said, just when it comes to hair, just get on with it. Just get on with it. My oncologist said, wouldn't it be great if we could live in a world where hair just didn't matter? I thought this comment was kind of out of touch at the time, but now I think it's perfect because really it didn't matter. I mean, like the grayish white color, or as I like to call it, white with black highlights. That was a bigger deal for me than being bald. So I currently have white hair with black highlights, au naturel. I do not know what my hair will look like next week or next month. I hope I will never rock a mullet. I'm getting close. But what I know, here's what I know, is women stop me on the street and compliment me on my hair color. You know, like they're about my age and they tell me they wish they had the courage to ditch their hair color like I did. Especially, you know, and as if it was by choice, right? So I smile and I say, thank you so much. So cancer refined me. So I may color it again one day, I don't really know. But for now, I'm doing what they call graying and slaying, right? Thank you. Just remember, don't get stuck on who you were before cancer. Embrace who you are now, okay? Tip number 6, you meet the best people for the worst reasons in life. It's really true. In the algorithm of lifetime risk, you will undoubtedly meet people who are just like you at some point. These days, your Instagram feed is even going to find them for you, okay? I always joke that my Instagram feed is dancers and cancers because my daughter's a dancer and it's like all I see is dancers and cancers. She's 14. So either through an internet search or word of mouth, you're going to meet people who just came through a surgery or a procedure, or people that you end up helping because they're behind you in the process. You're going to learn the true value of paying it forward because there will be women who gave you help that was life-saving to you, like what to expect at chemo number 4, or radiation, or what products work to prevent neuropathy, or whether to get implants or flap surgery, or which surgeons they liked and which surgeons you didn't like, everything. I still talk to the very first woman who helped me in 1998, Geraldine Lucas. She's gone on to write amazing books about her life during and after cancer. You ought to get her here because she's hilarious, okay? She wrote a book called Why I Wore Lipstick to My Mastectomy. She literally showed me her breasts in a public bathroom in New York City back in 1998 so I wouldn't be afraid of reconstructive surgery. She was diagnosed in her 20s and I was diagnosed at 30. You meet the best people. It's like the sorority that you never had a rush, but you know you're just in. And this brings me to my final tip, tip number 7. And this can be really hard, which is why I saved it for last. Remember the power of hope. Fear is a very powerful thing. It can be paralyzing if you let it. But hope is stronger than fear. What's an example? Look around the room, this room. Look at survivors. Who's a survivor here, ladies? Come on now. Look at all of you who are still with us. That's hope. Look at the number of metastatic patients living longer and longer lives. Yes, we have far to go, but we have come so far. I'm not my mother, may she rest in peace, but my mother's spirit guides me every single day. She taught me that struggle brings character. She had an optimism that was indescribable. As a gardener, I've tried to cultivate this optimism. I've watched various plants and fruits and vegetables in my garden sometimes look like terrible. But then I watch them like literally come back to life, more often than not. And maybe it's luck, and maybe it's water, or maybe it's just good compost. But sometimes in the worst of circumstances, a little hope goes a very long way. I'd like to think my lifetime risk has taught me many things: coping skills, perspective, the exaggerated importance we place as a society on hair color, the power of self-advocacy. But the biggest thing that it's taught me is courage. We all have it within us. In fact, there would be no courage without fear. Courage is the triumph over fear. And a lifetime of risk means a lifetime of courage. I do not know what the future holds for my health. I know I will eventually come off Lynparza and have at least one more surgery to change out my dinosaur saline implants. If I'm lucky, it will be a purely cosmetic procedure. It's really like the final chapter before I feel like I can truly put this cancer behind me. My cancer has an 85 to 90% survival rate. The drugs I'm currently on, my doctors tell me, could increase that survival rate to somewhere between 90 and 95%. It's a numbers game, and no one has a crystal ball. But I know that I will face my future with courage. I know that I believe in a future that I cannot see, and that's hard to do sometimes as well. But with hope and with courage and luck and good people surrounding me, the future is very bright. Thank you so much for letting me share my story. Thank you for keeping these discussions alive. Here's to thriving with lifetime risk, and here's to all of us being extraordinary. Here's to our health. Thank you.
Stacey, if you could stay there for just one moment. Do you want to take the mic, Dr. Chang?
Sure. Dr. Chang, one of the partners, on behalf of my partners, we would like to thank you for being here with us today, and thank you for empowering women to take control of their health, listen to their bodies, and to ask questions. Your talk was very impactful for me as a surgeon and taking care of these patients. I think embracing the gray is fine too. We'd like to present you with a Lifetime Achievement Award. Here you are.
Do you mind just taking a step over there?
Yeah.
We'll get a
Come
nice
here
picture.
this way. Thank you again. It was one of the best talks we've had here, so thank you again.
We'll have to let Joan know.
I know.
Awesome. Thank you so much.
Thank you, Stacey, for enlightening us, and thank you, everyone, for joining us here today. To each of our speakers, we're so appreciative of your contribution and all the information that you shared with us today. In addition, I'd like to express our sincere gratitude to each of our sponsors for their incredible generosity and dedication to breast health education and awareness. I specifically would like to thank Allergan and Compression Medical. They're our presenting sponsors. Thank you to our Pink Ribbon sponsors, MTF Biologics, New York Cancer and Blood Specialists, and Pure Mammography. Thank you, partner sponsors, Ivy Rehab, Polynovo, Renewal by Anderson, and Resensation. Your contributions have made this free community event possible. Thank you to the event staff that made today possible. Thank you to Lisa Mounier and the rest of our fabulous marketing team at New York Plastic Surgical Group. So once again, I apologize if we couldn't get to all of your questions. Your questions really are important to us. Like I said, if you're sitting here, chances are we have your email address. If we don't have your email address, you can come up to me and give it to me, because I will send you a survey. I want to hear your questions. We want your feedback. On behalf of myself and New York Plastic Surgical Group, thank you. I hope you enjoyed today's program, and we look forward to seeing you next year. Thank you.